Hai. Now I taking the laptop. Tahu tu ada apa? Nah, juga. Hah? Semua IT 的？IT 两个，两个吧？什么？没有啦，另外meeting 嘛，没有。这是阿信他们。你，是啊。这条又没有带那个，来了，现在。哎，这个来。好，继续笑。哎呀，他昨天破这个东西，我一直没有看到，去，应该没有事了吧？对啊，那个 NDSSC 11点早上，他问那个问题，但是我一直忘记去回他，我按了那个，他讲你的 website 那边有一个 NDSSC 那个 Webex。因为我需要找到。不知道。
SS。 Halo, halo, dengar tak? Testing, testing. Dengar tak?
Dengar.
Clear tak?
Clear.
Itu host dengan host jangan guna line sama. Satu pergi sebelah lah. Andrew pergi sebelah ke apa?
Hello, dengar kan?
Oh, dengar. You repeat lagi. You cakap lagi. Tengok cepat ke lambat.
Assalamualaikum. Okay, jap. Assalamualaikum and good morning to His Excellency Prof. Zamri bin Razzi, the Acting Chairman of Dental Deans Council. The Honorable Prof. Dr. Amia Baumik, the President of Lincoln University College, the past Chairman of Dental Deans Council, the respected Prof. Datuk Dr. Muhammad Ibrahim Abu Hassan. Okay tak speed ni?
Boleh. I mean like speed as in itu lag ke lag. Tak lag. Bukan speed you cakap lambat.
Oh, okay.
Okay.
Sorry.
Kalau you semangat sikit macam mana? Terlalu kuat.
Sebab diorang semalam suruh I tone
Jangan
down.
semangat sangat.
Jangan semangat sangat.
Oh, okay.
Okay je. Cuma
I think you punya you suruh mereka jangan stand behind you lah nanti.
Xavier. Ada satu orang panggil Putrajaya, dia nak masuk meeting. Xavier, your name. Equal format.
B. Lincoln University College. A truly global university. A top 25 performing universities in student mobility. That enhances lifelong learning opportunities, practical and scientific skills, social values, leadership and entrepreneurship. By harnessing information technology including machine learning and deep learning to create a noble, eternal, peaceful human society. Lincoln University College was established in 2002 and now has 3 campuses, which is 2 at Kuala Lumpur and 1 at Kota Baru. Lincoln University College Malaysia has been worldwide recognized by multi-rank universities, World University Ranking and also QS Asia University Ranking.
When she was just a girl, she expected the world, but it flew away from her reach. So she ran away in her sleep and dreamed of paradise, paradise. Every time she closed her eyes. When she was just a girl, she expected the world, but it flew away from her reach, and the bullets catching her teeth. Life goes on, it gets so heavy, the wheel breaks the butterfly. Every tear a waterfall. In the night, the stormy night, she closed her eyes. In the night, the stormy night, away she When she was just a girl, she expected the world, but it flew away from her reach. So she ran away in her sleep and dreamed of paradise, paradise. Every time she closed her eyes. When she was just a girl, she expected the world, but it flew away from her reach, and the bullets catching her teeth. Life goes on, it gets so heavy, the wheel breaks the butterfly. Every tear a waterfall. In the night, the stormy night, she closed her eyes. In the night, the stormy night, away she flies. I dream of paradise, paradise, paradise. Oh, she dream of paradise, paradise. sleep and dream of paradise, paradise. Every time she closed her eyes. When she was just a girl, she expected the world, but it flew away from her reach, and the bullets catching her teeth. Life goes on, it gets so heavy, the wheel breaks the butterfly. Every tear a waterfall. In the night, the stormy night, she closed her eyes. In the night, the stormy night, away she flies. A dream of paradise, paradise, paradise. Oh, she dreamed of paradise, so lying underneath those stormy skies. She said, oh, I know the sun will set to rise. This could be paradise, paradise, could be paradise. Oh, this could be
Food particles trapped between teeth and gums. Painful discomfort while eating. Difficulty cleaning braces and retainers. Children practicing poor oral care habits. When brushing teeth are just not enough. There is a solution. If you want a cool and clean feeling after brushing, for the brightest and healthiest smile possible, introducing Aquapic, the official recommendation of the Korean Dental Association. No more weak ordinary streams of water. Aquapic offers the most powerful pulsating stream at over 2,200 pulses per minute. Both safe and effective. You will be amazed by its cleansing power. Every part of your mouth will feel clean again. Aquapic effectively removes stubborn food particles and stains between the teeth and gums. No matter the shape or size of your teeth, it doesn't even matter if you wear braces. Normal brushing and flossing cannot remove all the hidden food residues hidden within your mouth, but with Aquapic, you can. Your teeth, something new and exciting is waiting for you. Aquapic.
Good morning, Professor Dato, Dr. Ibrahim. Good morning, Professor Jamri. And good morning, Professor Dato, Dr. Pusparajan. I'm not in Malaysia. I'm in Myanmar.
Oh, okay. Thank you. How are you, Professor?
I'm fine. Thank you, Dato.
How long have you been in Myanmar?
I just came yesterday over here.
Oh, okay. Right.
Today we have some graduation here in Myanmar.
Oh,
So I have to attend. And then I'm going back tomorrow, Dato.
oh no, short visit.
Short
You were
trip.
in South Africa last month, yeah? You said to me?
Yes, I was in South Africa, Dato.
Yeah, okay.
So I came back that I was in India last week, came back, now I'm in Myanmar.
Well, traveling a lot now. It's open, yeah?
We can very rarely see our president in Malaysia.
Thank you, Dato.
LUC, Lincoln University College. A truly global university. A top 25 performing universities in student mobility. That enhances lifelong learning opportunities, practical and scientific skills, social values, leadership and entrepreneurship. By harnessing information technology including machine learning and deep learning to create a noble, eternal, peaceful human society. Lincoln University College was established in 2002 and now has 3 campuses, which is 2 at Kuala Lumpur and 1 at Kota Baru. Lincoln University College Malaysia has been worldwide recognized by multi-rank universities, World University Ranking and also QS Asia University Ranking.
Preview. Preview. Preview.
Hi everyone, welcome to our virtual event, National Dental Student Scientific Conference 2022. This is a platform and also opportunity for dental students nationwide from dental university to exchange knowledge and also broaden their horizon. We truly appreciate everyone for spending your precious time with us today, and we're hoping for your continuous support throughout this long day event. We have a lot to cover today, but we should get started. But before that, we have prepared another short video for you. Let's begin.
Boosting knowledge, unmasking confidence. This is the National Dental Students Scientific Conference 2022. This year marks the 14th year of NDSSC, which will equip dental students with the right skills and insights to help them push forward in their careers, gain valuable in-time experience, and go greater heights together. So what are you waiting for? Buckle up and let's begin.
Assalamualaikum and good morning to His Excellency Prof. Zamri bin Razi, the Acting Chairman of Dental Deans Council, the Honorable Prof. Dr. Amia Baumik, President of Lincoln University College, the past Chairman of Dental Deans Council, the respected Prof. Datuk Dr. Muhammad Ibrahim Abu Hassan, our reputable Dean of Dental Faculty of Lincoln University College, Prof. Datuk Dr. Pushparajan Priyana Pillai, as well as our conference chairperson of the 14th NDSSC 2022, Mr. Lee Ji Peng Xavier, our invited speakers, distinguished guests, ladies and gentlemen. It is my pleasure to be the MC of the 14th National Dental Students Scientific Conference 2022. I am Humaira Zafira from the Dental Faculty of Lincoln University College. On behalf of the organizing committee, we wish to extend our warm welcome to all participants, guests of honors, delegates, and representatives from all the dental universities present here today. To begin the opening ceremony with blessings, I would like to invite Mr. Imran Shafiq bin Abdul Hisham to lead the Dua recitation.
Al-Fatiha. Bismillahirrahmanirrahim. Alhamdulillahi Rabbil Alamin. Wassalatu wassalamu ala Sayyidina Muhammad wa ala alihi wa ashabihi ajma'in. We express our gratitude to you for allowing us to attend assembly on this auspicious morning. O Allah, we ask you for the safety of our religion and the welfare of our body. O Allah, Lord of the implementing authority, make the days that we have gone through, starting with your mercy, continue with your blessing,
and ended with Thai forgiveness. And also make the days that we have gone through with guidance and end with the victory of excellence. Ya Allah, Ya Rahman, Ya Rahim. Let our efforts as a means to enlighten and convince ourselves that the personal safety of either outer or inner is a prerequisite for achieving happiness and excellence in various fields. O Allah, grant us faith and strength in order to face the challenges of life during the transition period and in the phase of life in this new era. Ya Zal Jalali wal Ikram. O Allah, show us guidance and adjust our path and ways to achieve happiness and glory. Let us listen to people who like the good things. Let us avoid doing the bad and evil things. O Allah, blesses our life in this meeting and gathering and prevents us from harm and unfortunate events. Allahumma ij'al jam'ana hadha jam'an marhuma wa tafarruqana min ba'dihi tafarruqan ma'suma wa la taj'alillahuma fina wa la ma'ana wa la min yatba'una shaqiyan wa la matruda wa la mahruma. اللهم اجعل خير أعمالنا آخره وخير أعمالنا خواتمه وخير أيامنا يوم ألقاك فيه. اللهم اغفر لنا ذنوبنا ولإخواننا الذين سبقونا بالإيمان ولا تجعل في قلوبنا غلا للذين آمنوا ربنا إنك رؤوف رحيم. ربنا آتنا في الدنيا حسنة وفي الآخرة حسنة وقنا عذاب النار. صلى الله على سيدنا محمد وعلى آله وصحبه وسلم والحمد لله رب العالمين.
Thank you, Mr. Imran. Excellencies, distinguished guests, ladies and gentlemen, today we have more than 300 participants, experts, and professionals joining this conference. We have all come together to broaden and exchange knowledge through this conference. Our theme for today is boosting knowledge and masking confidence. We strive to encourage learning and sharing among students of the dental field in Malaysia. This conference aims to provide a platform for discussion and exchange of ideas on dental care and oral health. Moreover, this conference will incorporate higher moral values, benevolence, and fighting spirit among dental students. We would like to extend our highest appreciation to our sponsors, Mark Endo Specialists, Aquapic, Endent, and MJ Dental Supplies. With your generous help, we are able to make this conference a successful one. Next, I would now like to invite the chairperson of the 14th National Dental Students Scientific Conference 2022, Mr. Lee Ji Peng Xavier, to deliver his welcoming speech.
Thank you, Kumara. Am I audible and visible?
Yes, Xavier.
Yes.
Good morning. I bid to the Dean of Dental Faculty of LUC, Dato Dr. Pusparajan Priyana Pillai, past Chairman of Dental Dean Council, Prof. Dato Dr. Muhammad Ibrahim Abu Hassan, Acting Chairman of Dental Dean Council, Prof. Zamri bin Razi, President of LUC, Prof. Dr. Amia Baumik, all the invited speakers, judges, guests, and all attendees here today. Thank you for being here with us today in this remarkable annual event of all the dental students in Malaysia, the 14th National Student Scientific Conference, NDSSC 2022. We are pleased to welcome all of you to witness the historical moment of the Faculty of Dentistry, Lincoln University College, as the host of this meaningful event. I'm Lee Zipeng Xavier, the chairperson of 14 NDSSC 2022. It was indeed my honor to be given the chance to be a leader for the organizing committee, and my sincere gratitude to each of everyone who has worked really hard in making this virtual event a successful one. I would also like to take this opportunity to congratulate all the participants who have been given the mission to represent our respected university to compete at national levels, and wish you all the best for the coming competitions. I really can't wait to see the delegates indulging into the event. So without further ado, I would like to welcome all of you to the 14th National Dental Student Scientific Conference 2022 with a theme Boosting Knowledge, Unmasking Competence. Enjoy the competition. Thank you.
Thank you, Xavier. I am now honored to invite our beloved Dean of Dental Faculty of Lincoln University College, Prof. Dato Dr. Pushparajan Priyana Pillai. Welcome, Prof.
Thank you very much, Humaira. I'm really extremely happy and honored to invite the students from the different dental faculties, the dean of the concerned dental faculties, and the academic staff and the support staff of the different dental faculties for this 14th National Dental Students Scientific Conference. I would like to make a special mention about Professor Dato Dr. Muhammad Ibrahim, our past president of the Dental Council. I have been associated with him almost for more than about 15 years, right from the time when I started my career, when I was a dean in the Penang International Dental College. He's a root cause for the recent advances that our dental field has acquired in Malaysia. Not only that, he is the initiating factor for starting this National Dental Students Conferences about 15 years back. And I have to sincerely thank him for all the guidance that has been offered by him during his presidentship for our Dean's Council. He has been a friend, a philosopher, and guide, not only to me, but for all the dental faculties and the deans of the concerned dental faculties. Thank you very much, Professor Dato Dr. Muhammad Ibrahim, for having accepted our invitation and having participated in this great event. Thank you very much.
My pleasure. Thank you.
And on behalf of the students of the LEC, I would like to extend my warm welcome to Professor Dr. Zamri, who is the Dean of the University of Malaya, which is one of the pioneer institutions which has started in the year 1972 or 73, I think. Thank you, Dr. Zamri, Professor Zamri, for having accepted our invitation and having participated in this great event. And I have got a very little time to say, but still I have to add up a few words about our President, Dr. Amia Moumik. He is a man of action. He has started the Lincoln University in a very small scale in Taman Mayang about 20 years back. And due to his hard work and extensive contact and his extensive public relationship, now there are about 140 programs which has been accredited not only in the locally but at international level. And as I have told you earlier, it is very difficult for us to meet our president because he has always been traveling. Maybe monthly about 20 days he will be in abroad, and monthly maybe 10 days. It is very difficult to get an appointment with him also. So when I asked him yesterday morning, sir, you should definitely participate in this event. He said he is going to Vietnam, but then he has accepted. I think the time now there is about 8 o'clock or 9 o'clock. So thank you very much, President. I am really happy that you have participated in this event. And my dear students, and I have to sincerely thank you for all the efforts that you have taken to conduct this 14th National Dental Students Scientific Conference. What's our goal? Our goal at the Faculty of the Dentistry of the different dental colleges and universities is to equip you students with the knowledge, skill, and self-confidence to enable all of you to become a very successful dentist in the world. Not only locally, you must spread over to the different countries and establish the name of our country and our university. All universities I am mentioning, not only the Lincoln, all the universities. And dear students, come and join with us. Let us embark on this journey together. My dear student, concentrate on your studies, understand the field, proceed to become a very, very successful person, not only in the field of the dentistry, any field that you undertake. And time is very short. I will finish my speech with this. Thank you very much. Thank you all.
Thank you, Prof, for the remarkable speech. It is with my pleasure to invite the past chairman of Dental Deans Council, the respected Prof. Dato Dr. Muhammad Ibrahim Abu Hassan, to share with us a few words. Welcome, Dato.
Thank you very much, Ms. Humaira, our MC this morning. President, Lincoln University College, Professor Dr. Amia, good friend of mine. Dean of Lincoln University College, Professor Dr. Pusparajan Pillai. Professor Zamri Radhi, Acting Chairman of the Malaysian Dental Dean Council, and all the 12 deans of dental, 12 deans of dental faculty in Malaysia. Our organizing chairman president, Mr. Xavier Lee, and all the participants in this auspicious event. Assalamualaikum and a very good morning. First and foremost, I would like to extend my sincere thanks to the organizing committee, led by Mr. Xavier and of course Advisor Professor Dr. Pusparajan for inviting me to say a few words at this auspicious event. Yes, this is the 14th year that we have, and unfortunately, this is the 3rd year running we are organizing as a online mode. But to continue the continuity of this program that we started 15 years ago. So as I said, this event is important because we bring the students together to share their experience, to share their knowledge, and to interact each other. But doing it online is a bit difficult. I mean, it doesn't. Of course, we can share the knowledge, but we are still missing the what we call the interaction, so physical interaction among students. So maybe in the next event, we can consider either hosting it either at least hybrid or full physical on conference. So we can see back our students can come and interact with each other to not just sharing the knowledge, but discuss other things that might be good for this building the career. Recently at UITM, we organized our conference, but we do it in a hybrid way, whereby, of course, in our conference, we have many events going on, but the peak event, we do it physical, but some other events, the supporting events, we do it on virtual. This is to avoid crowding in our facility. So Alhamdulillah, when we saw the physical event, the reaction of students are different, the interactions are different, and we have the speakers are also different. So it's easier to organize in terms of organization and expenses during online, but the impact is different if you organize through physical. So maybe in future, we can organize this event, in next year's event, inshallah, if things get better with the COVID, we can hold it physically when we can see our students interacting each other. That's what is important, that we need to culture among students together. So initially when Dr. Pusparajan asked me, how do we organize this event? Is it online or physical or whatever? So at that time, our situation, COVID, was not really good. So I said maybe for now, online might be a better one. But I think since it's getting better now, we hopefully that in future, I was told that UM will take over the next event. So we will have, say, at least if not full physical, it's a hybrid event. So again, I'd like to thank you all the organizing committee, Mr. Xavier, who has planned and very well. Of course, he did contact me a few days ago, and hopefully this conference this morning will go on well. And also Dr. Amia for for having to be able to join us with here from Myanmar. And of course, for the kind words, the introduction this morning. I wish all the best, and I wish all the participants who are participating in this event all the best. In fact, all of you are winners. So because that's why you are representing your university here. So it's just that we will see now who is a bit the lucky one today at the end of today. So all the best, and thank you again for inviting me for this opening ceremony of this 14th National Dental Student Conference. Thank you very much, and over back to you, Ms. Humaira.
Thank you, Prof. Datuk Dr. Muhammad Ibrahim, for that inspiring speech. I would now like to welcome Prof. Zamri bin Razi, the Acting Chairman of Dental Deans Council, to share a few words of wisdom. Welcome, Prof.
Thank you very much, Ms. Humaira, our Master of Ceremony. Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera, selamat pagi, and good morning. Yang dihormati Profesor Dr. Amia Bomik, Presiden Lincoln University College. Yang dihormati yang berbahagia Datuk Profesor Dr. Pusparajan Perena Pillai, Dean Faculty of Dentistry, Lincoln University College, our host today, the host of the conference. Yang dihormati yang berbahagia Profesor Dr. Muhammad Ibrahim Abu Hassan, past Chairman, Dental Deans Council of Malaysia, who are with us today. All dental deans who are also members of the Dental Deans Council of Malaysia, Mr. Lee Zimpeng Xavier, Chairperson of the 14th National Dental Student Scientific Conference, lecturers, speakers, sponsors, President of Malaysian Dental Student Association, MDSA, President of Asia Pacific Dental Student Association, APDSA Malaysia Division, and all the delegates. Today, 28 May 2020, is a special day. A day that Lincoln University College organized an awaited national event, 14th National Dental Student Scientific Conference. National Dental Student Scientific Conference, in short, NDSSC, is truly a national pride. And to the best of my knowledge, this is the earliest, this NDSSC is the earliest students' conference at national level, earliest of its kind, envious of many, where all the students gather to share their research findings, showcase their talents, and participates in various activities and competitions, as well as to socialize, to get to know others better. And this 14th NDSSC is again special as it marks a first complete cycle whereby all the dental faculties, dental institutions has been the host of this event. And today, we are very honored to have yang berbahagia Datuk Profesor Dr. Muhammad Ibrahim Abu Hassan, our past chairman of Dental Deans Council of Malaysia, the engineer and the architect of the dental education in Malaysia, as reiterated again and again by Datuk Pusparajan. With us today, yang berbahagia Datuk Profesor Dr. Muhammad Ibrahim has led DDS Dental Deans Council for more than 13 years and has witnessed the running of all the NDSSC from birth, from the beginning, and is the key person in making NDSS what NDSS is today. Throughout his tenureship as a chairman, he has transformed the dental education in this country, bring it to the frontier, and now our dental education, our national dental education, through many his initiative, became a reference to many other countries. We now became a reference, and there are so many other contributions done by him continuously, tirelessly. And ladies and gentlemen, we know that you are on mute, but today is the best day that we at our own station, at our own place, give a big round of applause to yang berbahagia Datuk. Thank you very much, Datuk. We really appreciate all your contributions to the country, to the nation, to our fraternity.
Thank you,
On
sir.
behalf of thank you, Datuk. Thank you again and again. On behalf of Dental Dean Council, we would like to congratulate Lincoln University College, deans, president, chairperson, everyone, and the organizing committee for organizing such a great NDSSC, for making this virtual conference a reality, for making this glorious event a success. To all the dental deans, thank you very much for all your support. We really appreciate your continuous support, undivided support to this event. As I said, this is our pride. And also, on behalf of the Dean Council, we would like to thank the sponsors who have given all the supports to our conference year in and year out. Your contributions meant a lot to our fraternity. We would like to thank everyone who are here today, and also to all the delegates and participants. We wish you all the best. Enjoy the conference. Have a nice day. Thank you very much again, and thank you.
Thank you very much, Prof, for that amazing speech. Now, lastly, let us invite the Honorable Prof. Dr. Amia Baumek, President of Lincoln University College, to share with us his welcome speech. Welcome, Prof.
Thank you, Ms. Sumara. All of you can hear me?
Yes, Prof.
Yes.
Okay. Assalamu alaikum and good morning to the past chairman of Dean Dental Council, Professor Dato Dr. Muhammad, and the current acting dean, as well as Dean of University Malaya Dental Faculty, Professor Jamri, and the Dean of Lincoln University College, Professor Dato Dr. Pusparajan, and all the deans of Malaysian dental faculties, universities, and most importantly, my beloved students who have joined today this 14th NDSSC. I must say, I was honored when our Dean, Dr. Pusparajan, told me just before leaving the airport that, can you join? I said, Dato, I wish I knew earlier, but I will try. So I am extremely happy to join. And I never take any opportunity to miss to student function. And how much I am happy to join the students organizing such a milestone event, especially my Lincoln University students who have taken these initiatives. Now, I am very pleased to see the slogan of 14th NDSSC 2022, boosting knowledge, unmasking confidence. The boosting knowledge, it comes with technical experiences, and unmasking confidence, it comes with soft skills. And I'm also pleased to see that the line and sentences and the space of unmasking confidence is more than the boosting knowledge. And that shows you can have technical knowledge 80%, But if you do not have good soft skills, you cannot win in your life journey. And I'm pleased to see that you have given the importance of soft skill knowledge. As I travel more than 110 over countries, I have experienced the students that you can have 80% best technical knowledge, but if you do not have that 20% of soft skill, you can lose in world platform. So, and with the soft skills, you can be a fantastic entrepreneur with the combination of technical knowledge. Now, when I say entrepreneur, it doesn't mean that you have to make money. Entrepreneur doesn't mean that you have to start a business. Entrepreneur meaning that unmasking confidence. Entrepreneur meaning the challenges in your life journey will come. You will never ever give up. When the challenges come, you will say, hey, let's embrace the challenges. Come up with strategic interventions, strategic plans, how you can come up or overcome that challenges. And that's the true example of entrepreneur, my friends. So today, the whole world is suffering lots of conflict. Look at Russia and Ukraine war is nothing but lacking of soft skills. So Russia is showing their power of technical knowledge and Ukraine is showing their soft skill knowledge. That's the differences. So let's pray together that the whole world suffering of that soft skills, and if we enhance that soft skills, we all in this earth live very peacefully as a human being. We are all brothers and sisters. No one is different from each others. So this is a platform, and I'm very, very pleased to see that especially the Dental Council have taken that initiatives 15 years back to boost our young students to become leaders, and not only in Malaysian dentist profession, but throughout the world. So let's pray hope that as we live in this world, and I always say, my friend, we are tourists in this world. We will live for few years. So when we leave, we should create our soft skills in such a way, leave your mark in this world, that we came to this world for a purpose and we have delivered. So when we leave, people will remember not only for your technical knowledge, but your soft skills, what you have said, unmasking confidence. So let us pray together to Almighty that we enhance our soft skills so that we create an impact in the society and the entire human society. Bless us that we live in this world peacefully and harmoniously. Once again, I appreciate the organizing chairman, Javier Lee Ji Feng. He is constantly in touch with me that I make sure I do not miss anything. I appreciate Javier and your team members that in spite of COVID and virtual, but all of you, along with the students of other dental faculty, showing a showpiece throughout the world dentistry. I pray all of you continue to have such leadership quality, and may Almighty Supreme God and Allah help us to live in this world peacefully. Thank you and God bless.
Thank you, Prof, for sharing your words of wisdom. Now, to commemorate the event, I would like to invite Prof. Zamri bin Radzi, Prof. Dr. Amia Baumik, Prof. Dato Dr. Muhammad Ibrahim Abu Hassan, and Dato Dr. Pushparajan Priyana Pillai to join Mr. Xavier to officiate the 14th NDSSC 2022.
Prof. Dr. Sharista, we
We
declare the conference officially open.
We declare the
Conference
conference officially
officially
open.
Thank you, Dato, Prof, and Doctor.
Congratulations.
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 Thank you. Thank you, Xavier.
Congratulations, Xavier.
Thank you, thank you.
With that, it is official that the 14th NDSSC 2022 begins. Thank you for your attention. Now let us proceed to have a 15-minute coffee break, and we will return to parallel session at dedicated rooms. Thank you.
Thank you.
Thank you, Humaira. You are a fantastic MC. Dato Dean, please reserve her. By the way, Humaira, all of you should invite your dental students for your Monday Haridaya open ceremony.
Yeah, I also forgot to mention, make a mention about it. On Monday, we are going to have a Raya opening function. Okay, so I request all the students from year 1 to 5 to participate in this one and make the function a grand success. Thank you, Xavier. You have really taken immense pain to conduct, to organize this event. Thank you, Xavier, and also Humaria. Thank you.
Dato, also you can invite other deans and students to join your Raya function. Why you want to make it very only one? Invite.
Sure, sir. I welcome all the students from the different faculties, deans, and other academic staff also to come and join with us for this event, please. Thank you very much. Thank you, sir, Mr. President, and
Food
Dr.
particles
Zamri.
trapped between teeth and gums. Painful discomfort while eating. Difficulty cleaning braces and retainers. Children practicing poor oral care habits. When brushing teeth are just not enough. There is a solution. If you want a cool and clean feeling after brushing, for the brightest and healthiest smile possible, introducing Aquapic, the official recommendation of the Korean Dental Association. No more weak ordinary streams of water. Aquapic offers the most powerful pulsating stream at over 2,200 pulses per minute. Both safe and effective. You will be amazed by its cleansing power. Every part of your mouth will feel clean again. Aquapic effectively removes stubborn food particles and stains between the teeth and gums. No matter the shape or size of your teeth, it doesn't even matter if you wear braces. Normal brushing and flossing cannot remove all the hidden food residues hidden within your mouth, but with Aquapic, you can. Your teeth, something new and exciting is waiting for you. Aquapic.
Ladies and gentlemen, you can now proceed to the parallel breakout rooms. Thank you.
Poor oral care habits. When brushing teeth are just not enough, there is a solution. If you want a cool and clean feeling after brushing, for the brightest and healthiest smile possible, introducing Aquapic, the official recommendation of the Korean Dental Association. No more weak ordinary streams of water. Aquapic offers the most powerful pulsating stream at over 2,200 pulses per minute. Both safe and effective. You will be amazed by its cleansing power. Every part of your mouth will feel clean again. Aquapic effectively removes stubborn food particles and stains between the teeth and gums. No matter the shape or size of your teeth, it doesn't even matter if you wear braces. Normal brushing and flossing cannot remove all the hidden food residues hidden within your mouth, but with Aquapic, you can. Your teeth, something new and exciting is waiting for you. Aquapic. particles trapped between teeth and gums, painful discomfort while eating, difficulty cleaning braces and retainers, children practicing poor oral care habits. When brushing teeth are just not enough, there is a solution. If you want a cool and clean feeling after brushing, for the brightest and healthiest smile possible, introducing Aquapic, the official recommendation of the Korean Dental Association. No more weak ordinary streams of water. Aquapic offers the most powerful pulsating stream at over 2,200 pulses per minute. Both safe and effective. You will be amazed by its cleansing power. Every part of your mouth will feel clean again. Aquapic effectively removes stubborn food particles and stains between the teeth and gums. No matter the shape or size of your teeth, it doesn't even matter if you wear braces. Normal brushing and flossing cannot remove all the hidden food residues hidden within your mouth, but with Aquapic, you can. Your teeth, something new and exciting is waiting for you. Aquapic.
LUC, Lincoln University College. A truly global university. A top 25 performing universities in student mobility. That enhances lifelong learning opportunities, practical and scientific skills, social values, leadership and entrepreneurship. By harnessing information technology including machine learning and deep learning to create a noble, eternal, peaceful human society. Lincoln University College was established in 2002 and now has 3 campuses, which is 2 at Kuala Lumpur and 1 at Kota Baru. Lincoln University College Malaysia has been worldwide recognized by multi-rank universities, World University Ranker.
Participants, I would like to remind you again that you can now join the parallel breakout rooms, and you can find the link in the chat box. Thank you.
LUC, Lincoln University College. A truly global university. A top 25 performing universities in student mobility. That enhances lifelong learning opportunities, practical and scientific skills, social values, leadership and entrepreneurship. By harnessing information technology including machine learning and deep learning to create a noble, eternal, peaceful human society. Lincoln University College was established in 2002 and now has 3 campuses, which is 2 at Kuala Lumpur and 1 at Kota Baru. Lincoln University College Malaysia has been worldwide recognized by multi-rank universities, World University Ranking and also QS Asia University Ranking. LUC, Lincoln University College. A truly global university. A top 25 performing universities in student mobility that enhances lifelong learning opportunities, practical and scientific skills, social values, leadership and entrepreneurship. By harnessing information technology including machine learning and deep learning to create a noble, eternal, peaceful human society. Lincoln University College was established in 2002 and now has 3 campuses, which is 2 at Kuala Lumpur and 1 at Kota Baru. Lincoln University College Malaysia has been worldwide recognized by multi-rank universities, World University Ranking and also QS Asia University Ranking.
तेरे नीले नीले नैनों से शबनम पी लूं, तेरे गीले गीले होठों की सरगम all that you really want. Disappearing when you wake up. But there's only getting no radar. Even when I'm thinking about changing, it will never change my crazy. You snap and change it. It will never change you ever dreamed of. Disappearing when you wake up. But there's nothing to be afraid of. Even when life changes, it will never change me and you.
The club isn't the best place to find a lover, so the bar is where I go. Me and my friends at the table doing shots, drinking fast and then we talk slow. Come over and start up a conversation with just me, and trust me, I'll give it a chance. Now take my hand, stop it, and the man on the jukebox, and then we start to dance. And I'm singing like, girl, you know I want your love. Your love was heaven.
Going out tonight changes into something red. Her mother doesn't like that kind of dress. Everything she never had, she's showing up. Driving too fast, moon is breaking through her hair. She's heading for something that she won't forget. Having no regrets is all that she really wants. Only getting older, baby, and I've been thinking about it lately. Does it ever drive you crazy? Just how fast the night changes. Everything that you've ever dreamed of disappearing when you wake up. But there's nothing to be afraid of. Even when life changes, it will never change me and you. Chasing it tonight, doubts are running round her head. He's waiting, hides behind a cigarette. Heart is beating loud and she doesn't want it to stop. Moving too fast, moon is lighting up her skin. She's falling, doesn't even know it yet. Having no regrets is all that she really wants. We're only getting older, baby, and I've been thinking about it lately. Does it ever drive you crazy? Just how fast the night changes. Everything that you've ever dreamed of disappearing when you wake up. But there's nothing to be afraid of. Even when night changes, it will never change me and you. Going out tonight changes into something red. Her mother doesn't like that kind of dress. Reminds her of a missing piece of innocence she loves. Only getting older, baby, and I've been thinking about it lately. Does it ever drive you crazy? Just how fast the night changes. Everything that you ever dreamed of disappearing when you wake up. But there's nothing to be afraid of. Even when the night changes,
universities in student mobility. That enhances lifelong learning opportunities, practical and scientific skills, social values, leadership and entrepreneurship. By harnessing information
like that kind of dress, everything she never had, she's showing up. Driving too fast, the moon is breaking through her hair. She is heading for something that she won't forget. Having no regrets is all that she really wants. I'm only getting older, baby, and I've been thinking about it lately. Does it ever drive you crazy? Just how fast the night
我开始啊，这边听到啊？Hello，听到吗？我讲1、2、3。
Yes, start.
Okay. A very good afternoon to all the participants and the lecturers. And today for the Dental Forum speaker, I would like to introduce Dr. Mark and also Dr. Lim. Sorry. 听到how is it, Xavier?
Good. Can read it like.
So this is just a testing 1, 2, 3. So for the first lecture title will be false positive and false negatives in endodontics. And for the introduction, there are times when we can't trust what we see, hear, and feel when we are dealing with pulp tissues. Circumstances involved may be at the diagnostic, operative, and post-treatment stages.
mobility that enhances lifelong learning opportunities, practical and scientific skills, social values, leadership and entrepreneurship. By harnessing information technology including machine learning and deep learning to create a noble, eternal, peaceful human society. Lincoln University College was established in 2002 and now has 3 campuses, which is 2 at Kuala Lumpur and 1 at Kota Baru. Lincoln University College Malaysia has been worldwide recognized by multi-rank universities, World University Ranking and also QS Asia University Ranking. LUC, Lincoln University College. A truly global university. A top 25 performing universities in student mobility. That enhances lifelong learning opportunities, practical and scientific skills, social values, leadership and entrepreneurship. By harnessing information technology including machine learning and deep learning to create a noble, eternal, peaceful human society. Lincoln University College was established in 2002 and now has 3 campuses, which is 2 at Kuala Lumpur and 1 at Kota Baru. Lincoln University College Malaysia has been worldwide recognized by multi-rank universities, World University Ranking and also QS Asia University Ranking. LUC, Lincoln University College. A truly global university. A top 25 performing universities in student mobility. that enhances lifelong learning opportunities, practical and scientific skills, social values, leadership and entrepreneurship. By harnessing information technology including machine learning and deep learning to create a noble, eternal, peaceful human society. Lincoln University College was established in 2002 and now has 3 campuses, which is 2 at Kuala Lumpur and 1 at Kota Baru. Lincoln University College Malaysia has been worldwide recognized by Multirank Universities, World University Ranking and also QS Asia University Ranking. LUC, Lincoln University College.
Food particles trapped between teeth and gums. Painful discomfort while eating. Difficulty cleaning braces and retainers. Children practicing poor oral care habits. When brushing teeth are just not enough, there is a solution. If you want a cool and clean feeling after brushing, for the brightest and healthiest smile possible, introducing Aquapic, the official recommendation of the Korean Dental Association. No more weak ordinary streams of water. Aquapic offers the most powerful pulsating stream at over 2,200 pulses per minute, both safe and effective. You will be amazed by its cleansing power. Every part of your mouth will feel clean again. Aquapic effectively removes stubborn food particles and stains between the teeth and gums. No matter the shape or size of your teeth, it doesn't even matter if you wear braces. Normal brushing and flossing cannot remove all the hidden food residues hidden within your mouth, but with Aquapic, you can. Your teeth, something new and exciting is waiting for you. Aquapic.
University College. A truly global university. A top 25 performing universities in student mobility. That enhances lifelong learning opportunities, practical and scientific skills, social values, leadership and entrepreneurship. By harnessing information technology including machine learning and deep learning to create a noble, eternal, peaceful human society. Lincoln University College was established in 2002 and now has 3 campuses, which is 2 at Kuala Lumpur and 1 at Kota Baru. Lincoln University College Malaysia has been worldwide recognized by multi-rank universities, World University Ranking and also QS Asia University Ranking.
So a very good afternoon to everyone, to the participants, to the lecturer, Dr. Mark Lau Jun Fei, and also Dr. Lim. So today we'll be having a dental forum, which is we have an outside speaker by Dr. Mark and also Dr. Lim. And to begin with the event, I would like to introduce the first title for the first lecture title, False Positive and False Negative in Endodontics. There are times when we can't trust what we see, hear, and feel when we are dealing with pulp tissues. Circumstances involved may be at the diagnostic, operative, and post-treatment stages, where irreversible decisions can lead to significant difference to patients. Numerous misinterpretations and observations will be explained so that necessary precautions can be taken to avoid iatrogenic errors, which is caused by the dentist. Yes. For the introduction, for the first speaker, Dr. Mark completed his secondary education in Victoria Institution, Kuala Lumpur, and then he's currently the course leader in endodontics at Lincoln University College, and a visiting endodontist at Eye Care Dental Tri Damansara. His Facebook page, Mark Endo Specialist, is dedicated to share on his knowledge and clinical experience. Please welcome Dr. Mark.
Hi, good evening. Just want to test my mic before we begin. Yusuf, can you hear me from your side?
Yes, doctor.
Okay,
It's very clear, yes.
That's great. It's good to see you folks here, and I'm honored to be invited to share whatever that I know. I'll be always happy to do that. So to start off, I'm just going to share my screen first. Okay. Right. So here you go. I've just a few slides short of 80 to share in under an hour. I hope I have enough time to cover everything. In case if I have to rush through, you can always get back to me if you have more questions, right? So why do I want to talk about this? See, I wish there are a lot of this that my lectures taught me when I was a student, because after I graduated, there are a lot of uncertainties, you see. Not to say we didn't have a good teacher, but there are things that sometimes it is not 100% certain. So we are dealing with a lot of gray areas in endodontics, and it helps if there is someone to guide us and to share with us their experience. Okay, so to understand what I want to talk about, I will not talk much about statistics. But of course, it helps if you can understand terms like sensitivity, specificity, okay, PPV and NPV, okay. These are all for exam purposes. If you're sitting for some Royal College exams, okay, these are things that you will have to find out and you have to read up. But our session today is something of a more casual one. There aren't many of us around, so just sit back and relax, okay? It's all spoon feeding. So type 1 error. It's akin to saying, well, it's not supposed to be there, but we are seeing it, okay? In this example, we are saying that this man is pregnant. It's obviously not. Whereas for false negative, the condition exists. It's just that our test is not sensitive enough to pick it up. So in this case, this pregnant lady, well, the doctor is saying that she's not pregnant, which is obviously false. Okay, so with these two kind introduction, I hope we get some good idea on what we will about to go into. Okay, gonna skip this. No time for joke today. So this is the content of my lecture. I'm gonna cover a lot from pre-op to mid-op to post-op. Okay, to start off, patients that reported pain, we will generally categorize them into two different scenarios, whether they are having reversible or irreversible pulpitis. But you see, not all patients will present with characteristic pain like this, you see. Sometimes their presentation is more vague, okay? Sometimes it can be a little bit of both, and that can really confuse us because patients do not often report textbook-like characteristics. So, turns out there's actually a very good rationale behind what patients reported in terms of pain correlates very, very poorly with the histopathology that is taking place in the pulp. These are proven in some very old studies, okay? For example, if a patient is complaining of severe pain, sometimes if you extract the tooth and if you have to check under the microscope, the pulp can be probably mildly inflamed. There may not be even any sign of inflammation. For example, presence of PMN cells, okay? So what we understand is that pain is subjective. Why is that important to us? When there is pain, okay, patient may not necessarily is experiencing irreversible pulpitis, but when there is no pain, it doesn't mean that the pulp is healthy. So this term actually wasn't available. Nobody introduced this term when I was a student. Okay? Asymptomatic irreversible pulpitis, meaning the pulp is already very, very unhealthy. If you are to expose the pulp, the bleeding from the pulp just oozes out, and a natural pulp shouldn't be like this. A natural pulp should stop with some light pressure with some moist cotton palette, okay, in under 10 minutes. You never know. Sometimes you will only find this out by chance if the pulp is exposed. For example, during caries excavation. Okay, so that boils down to us on what we can do to perform our examination on the patient. To start off, we of course do not jump straight into radiographs, but I'm going to talk about radiographs first because I have a lot of pictures to share. See, we have to be able to discern cervical burnout from caries. Okay, caries typically occurs right around the contact area or the contact spots. Okay, but if you get cervical burnout, it's usually a lot closer to the alveolar bone crest. And for cervical burnout, the lesion is usually sharp, okay, wider sometimes. And if you have a digital processing system, for example, if this is a digital radiograph, you can just adjust the contrast or the brightness and you can see back suddenly some structure appearing over here. But you can't do that with caries, you see. Caries, you can see a very obvious break in the enamel right next to the contact point, okay? And sometimes right after the enamel, you can see some darkening of the dentine. This is very, very characteristic of dentine. Caries. Okay. All right. Next, you need a good bite wing to detect initial caries and interproximal caries. Can you rely on periapical radiographs? You can to some extent, but if your form is distorted, if it is not taken at an angle, okay, at an angle that is well parallel to the long axis of the tooth, you will get a very, very different picture. For example, in this slide, for the bite wing, you can see a very obvious decay over here, but somehow when a periapical radiograph is taken, the size of the caries somehow has significantly reduced. Now just imagine if you have a very small decay underneath this amalgam. Obviously, when you take a periapical radiograph, you may miss that entirely. So just be careful. The gold standard is, till now, is to take a bite wing, okay, to rule out presence of initial caries. Okay, but if you are to take a periapical radiograph, just make sure it is as parallel as possible to the tooth long axis. Okay, another example from my Facebook page. Okay, you can see decay here, but somehow it just disappeared on another phone. Okay, next about the assessment of the root canal outline. Okay, what you see really depends on the angle of the radiograph. Depending on the tilting of the film and the tilting of the X-ray beam, the same tooth may appear to have just one canal, or a canal that disappears halfway mid-root, or you can clearly see sometimes branching of the canal. So what is this picture telling us? Of course, if you can take a radiograph in a parallax manner, that'd be good. But some cases, you just need to take 2 radiographs to rule out certain things that are very, very common. Okay, moving next, confusing radiolucent landmarks. There are times we see some darkening of the root apex, which may actually signal us that there could be PDL space widening. But please be careful, especially when this region is superimposed on some radiolucent landmark. For example, the ID nerve, or some cases, the incisal foramen, the incisal canal, and sometimes the mental foramen. Okay, so if there is some PDL space widening, or even some radiolucent lesion right at the apex, properly performing sensibility tests is actually very important. Okay, for all you know, the PDL space widening could be due to occlusal trauma. Okay, what about invisible PA lesions? Are there such a thing? Yes. Nowadays, we're detecting more and more things with better technology. For example, in this periapical radiograph, I think I cropped this from Abela 2013. Okay, the root seems to be reasonably healthy with no any sign of PDL space widening or PA lesion. Okay, but this can be very different if you have to take a CBCT scan. There is an extensive PA lesion or loss of bone structure around the root. Okay, and these can sometimes be blocked because of the close proximity of the root, PA lesion hiding behind the root, or sometimes there's a very thick buccal cortical plate. Okay, another sign, sometimes with just some very initial inflammation of the periapical tissue. Okay, this is actually very clear from a CBCT slice, but because of the thick buccal cortical bone plate, okay, you may not be able to pick it up from your radiograph. I mean periapical radiograph. Okay, some similar observation. Okay, so CBCT could be useful if you have a row of suspects. Okay, all teeth are heavily restored. You just do not know where is the pain coming from. And this is one of the criteria, confusing signs and symptoms that do not match patient's presentation. So CBCT. All right. I'm not going to pop this up in any of your screen. Okay. But of course, my students should know this. What should be your first line when it comes to sensibility tests? Okay. The answer is co-test. It's not electric pulp test. It's not hot test. And it's definitely not COVID test. So why co-test? Because that's the most common symptom that patients may report when they're having irreversible pulpitis. That is sensitivity to thermal changes. They will not say, oh, they're sensitive to electrical current. No one will say that, okay? Unless they're dentist's son or, I don't know, kids, okay? Cute. Myth number 2. Will painkiller mask the response of sensibility tests? A lot of your patients could have taken some form of painkiller before they come to see you, and you may sometimes doubt yourself whether you're performing the right thing. Okay, and I'm glad that there are studies that have pointed out that NSAIDs or any painkillers, majority of them, they do not affect your sensibility test significantly. Okay. Now, moving next on cold test. When we are talking about cold test, we want something that is so cold that can just penetrate any layer of insulation on the tooth to get all the way to the pulp and stimulate the C fibers or the A delta fibers. Okay, so in this picture, okay, I think some faculties, they have ethyl chloride. This is actually not suitable for cold test in endodontic diagnosis. It's just not cold enough. You need something that can give you -50 Celsius degree. By the time you carry this cotton pellet into the mouth, and when the cotton pellet touches the tooth, you will not get -50 anymore. You probably get about -20. So now try to imagine this. This is about -7 at presentation. By the time you bring it into the mouth, it'll be like 4, 5 Celsius degree. It's just not cold enough. Some people use ice sticks, and these ice sticks can be formed by using a vacant or an empty LA syringe, okay, or not syringe, sorry, LA cartridge, or some needle hub, okay. This is prone to false positive because when ice melts, the water can drip onto the adjacent structures, okay. This technique was quite commonly used in the past, but now not anymore. Okay, when you're spraying cold test, when you're performing cold test, please spray the cotton pellet adequately. You want it to be as moist as possible without any of the solution dripping on the patient's soft tissue or hard tissue. Okay, when you get it to this moist, it should look frosty. You apply it immediately on the tooth surface. But just a simple reminder, some patients who are already complaining of severe pain, okay, from cold, please be careful. You still have to perform cold tests on patients who are complaining with a tooth with thermal sensitivity. Okay, the answer is yes. Now, why? Okay, the explanation is very important because some patients, the culprit of the toothache can be coming from more than one source. Okay, there can be 4 or 5 teeth, and the patient may need 2 or 3 root canals, but the patient is only pointing at one tooth. And if your treatment doesn't work out, they may actually tell, hey, you're doing something wrong, probably you mess up somewhere. So it's important to get your diagnosis right. You need root canal on 2, 3 teeth before you even tell them, okay, what they need before even you start any of your treatment. Okay, get your diagnosis complete before you start your treatment. Okay, how long must you apply the cotton pellet on the tooth? Answer, sometimes it may take up to 15 seconds, especially patients with sclerosed pulp chamber, okay, especially patients with very high pain threshold, okay, but routinely you should be able to pick up some response from the patients by applying the cotton pellet by just 4 or 5 seconds, okay. The trick here is sometimes you can read their eyes. They will have some reaction on their eyes, so please do not give them a dark goggles. In the past, I'll ask them to raise their hand, but sometimes they only raise their finger, or sometimes they just say, eh, eh, eh. So the best way to read their response is to see their face and their eyes. Okay, when we're talking about sensibility tests, there are 4 things that everyone must know, okay, because each of these can give rise to false response. Metal restoration, gingival contact, excessive moisture, and poor tip wall contact. Because if any of these 4 is present, this can actually conduct the thermal changes or even electricity to the adjacent structures. Okay, so let's have a look on these pictures. Okay, you should be able to understand more. Say when we are testing on an incisor, upper incisor, this is the easiest tooth to test. Okay, now you got to dry the teeth adequately, and then you have to retract the lip and the cheek adequately. You do not want any saliva to get near the surface that you want to test. Obviously, this is a little more challenging for your lower teeth, but it is important that your assistant is standing next to you, holding a suction, preferably not too near to the tooth that you want to test, to clear the saliva, and probably the assistant should also be holding another mouth mirror to retract the tongue, just to keep the tongue out of the way from touching the posterior teeth. Okay, again, the sulcus has to be dry. There shouldn't be any pulling of the saliva. Okay, and the tooth, the surface has to be dry. Okay, for posterior teeth, okay, for anterior teeth, I think you should already know. You test it on the labial surface, perhaps somewhere near the incisor third, but you should never place any of the contact near the gingiva. Okay, because sometimes you never know. The gingiva could be the one that's stimulated instead of the pulpal tissue. Okay. For posterior teeth, sometimes there are a lot of restorations that may be present. Okay, for example, extensive amalgam restoration. Sometimes the amalgam could be touching the gingival tissue already. So you may want to be careful in cases like this where when you want to test the tooth, please test it on a surface, non-metal surface. Probably I'll pick mesial buccal cups because of the proximity of the pulp horn, okay? But try not to put it directly on the restoration, okay? Again, gentle reminder, please dry the surface adequately. What about cases with severe extensive decay with a very big hole? Where do you put? Should you put it on an intact tooth structure? So the answer is if there's already a very big hole, directly put the cotton pellet inside the hole. That is the fastest way you can stimulate the pulp chamber, the pulpal tissue. Okay. If, for example, the buccal wall is too thin, okay, the hole is very big. If you are just touching the buccal wall shelf, very little thermal changes can take place. Okay, EPT. I hope you can see this celluloid strip that is isolating this incisor that this clinician is testing. So why is this celluloid strip important? Because occasionally, electrical current can transmit to the adjacent structures, particularly if the surface is wet, or number two, there is some restoration, okay? Number three, okay, the probe is placed not at the center or likely somewhere near to the proximal surface. Who would put a probe on the proximal surface? Now try this on a patient with very small mouth and on a posterior tooth, for example, 7. You will run out of place to place your tip, okay? So probe tip contact with the surface is important. You have to make sure that the tip is resting on the surface in a stable manner. Your finger shouldn't be trembling. Toothpaste. I know we are all poor, at least in the faculties. At least if you're using expired toothpaste, please make sure that the toothpaste still look like some toothpaste, okay? So how much medium should you place? Not much, just enough for the current to pass from the tip to the tooth. Just some very little smear, enough, okay? So again, back to these pictures, where should you put? It's just about the same with your co-test application earlier. Avoid areas that can have contact with metal restoration. Okay, avoid areas that are wet. Avoid areas that are near the gingiva, and of course, please place the tip properly on the surface you want to test. Now, this may sometimes be a problem, say in a few scenarios. Okay. I'm going to cover about that scenario in a while, but just let me explain about this picture first. This is actually a very, very old machine, a very, very old electric pulp test machine. Okay, what I want to show you here is the number. Okay, you can see a very obvious 2-digit here, 21. Okay, is this significant at all? Okay, here's another thing that I need you to understand. This machine is testing nerve response of the pulp, not blood supply of the pulp. Okay, that's number one, point number one. Point number two is tooth vitality depends on circulation, pulpal circulation, not the intactness of your neural supply. Okay, so even if the nerves are damaged, even if there is no blood, okay, even if the nerves are damaged, or sometimes even if the patient responded in an exaggerated manner, you will not know for sure what is the level of blood circulation. You will never know for sure if there is even any blood circulation, because some cases, the nerves can still survive even though there is no longer any pulpal blood flow. Okay, that's number one. And number two, pain is subjective. And number three, there are studies have already shown that this reading correlates very, very poorly to the histopathology of the pulp. Okay, what does this mean? Okay, just understand, this machine is only highly accurate when the reading is already max but there's no response on the patient. Okay, meaning this machine is only highly accurate to detect pulp necrosis, but it is not good enough to detect irreversible pulpitis. Okay, so the reading here, if for example, you get incisors, okay, 1 2 1 1 2 1 2 2, you get reading like 12, 22, 32, 8. Will that mean anything? No. Sometimes, well, that depends on the probe contact, and also some teeth may have some sclerosed chamber, some teeth may have some extensive restoration, some teeth you just don't know where to put. There's deep caries here, amalgam filling there. So again, the number does not matter. What you want to know is that is there response on the patient, or if there's no response. If there's no response, despite properly executing this test, likely there's pulp necrosis. But if there's exaggerated response on one sole tooth, but the adjacent teeth appear to be fine, then you have a very good reason to suspect that maybe that tooth is having irreversible pulpitis. But just so you know, sometimes this machine will not help you at all to find out where's the culprit. Okay, so these are the papers that back up my claims earlier. A lot. These are nothing new, but somehow we are still writing the value, and we think that the value carries some sort of significance. Okay, now what about the machine itself? Electric pulp test employs the use of a digital device. If there's something wrong with the device or the circuit, whatever that we can pick up may no longer be accurate. Okay. Just before that, okay, just want to share a little more. Old machines particularly, sometimes when the battery is weak, the machine may not be able to produce enough current to stimulate the pulp, despite seeing the changes in the number on the panel. Okay, that's point number one. If your machine isn't working, please test with a newer machine. Sometimes you can get two different results. Number two, your reading will depend on the circuit. If there's a break in the circuit, for example, the wire here isn't plugged properly, or number two, the hub here is severely damaged. You know, when you keep your wire, for example, your handphone charger, your wire shouldn't be kinked 180 degrees, right? There cannot be sharp bend. Okay, you should roll it gently. Say this happens in the faculty a lot. We just bundle up the wire together, and sometimes there can be internal damage in the wire. You just can't see it because there's rubber tubing all along. Okay, and number three, battery level. That one I've told you already. Okay, right. Any electrical devices are like that lah. They will not last forever, and up to some point you will have to get a new one. Okay, next, when you're performing electric pulp tests, what exactly are you testing? Okay, you want to bring electrical current to stimulate these little fella, these nerve fibers that may be contacting the odontoblast, or sometimes it may just be nearby, okay, near the odontoblast. Okay, now problem comes is that when there are kids, pediatric patients, I think you're aware of this already, electric pulp test is not that accurate on kids. Why? Because these nerve fibers, the development isn't complete. Okay, the pulp horn isn't even mature. There may probably not be even many nerves around the pulp horn, so you can't test it. So if EPT doesn't work, you have to use cold test. Okay, right. Another issue, crown tooth. Where are you supposed to test it? If you're lucky, sometimes there can be gingival recession, and there can be some exposed dentin. So if your tip is small enough, you can just contact this exposed dentin. But sometimes you do not have such a luck, you see. So that's why when you do, let's say a PFM crown or any crown at all, please design it to have some margin, okay, that allows some tooth structure to be exposed. I'm talking about vital pulp now, so that in the event when you want to perform sensibility tests in the future, the dentist will have a far more convenient way to place their probe. Okay, but let's say if you have no chance at all, no choice at all, you have no space at all, what can you do? This is what I've been doing all along. Get a sharp probe, rest on the exposed dentin. Sometimes you have to retract the gingiva a little bit by using a plastic instrument. Okay, you have to do that gently without inducing pain. Okay, and then this is very important. sometimes the rest between your probe tip and the probe is not stable. There has to be enough medium, okay? And if this technique still do not work, if your heat test fail, your cold test fail, you're left with sometimes just selective anesthesia or cavity test. Okay, no choice. Okay. So other causes of false responses. Okay, multi-rooted teeth, very famous. You do cold test, seems okay. So sometimes, yes, the response seems normal, but because there are multiple roots, one of the roots could be necrotic already. Somehow, it's just not prominent enough for the patient to confidently tell you that this tooth is the culprit. Okay, anxious patients, kids, but adults can be anxious too. You can tell even from a simple checkup, their back will be so sweaty. They're really not kidding. Okay, next, elderly patients with closed tubules and sclerotic chamber. This is very troublesome, not easy. For some cases, I would hope to refer the patients for CBCT, but we can't do that right immediately. So sometimes EPT and co-test just can't stimulate anything. Okay? And recent orthodontics, patients who have just concluded their ortho treatment, or if they're still on braces, EPT reading somehow you don't get a reliable reading. Put already, it's as if you do not do the test at all. You do not even know what you do not even know what to tell the patients. Okay, is this pain? Is this not pain? There's something, but it's not pain. So it's not useful at all. Okay, next, this is important. Sensibility tests within 3 months following dental trauma is expected to be negative. Okay, simply because the nerves are damaged, but blood circulation is still intact. And this false negative period can stretch up to a year. Okay, so I've posted about this in my Facebook, I think quite some time, I think easily more than a year ago. I wanted to share on the differences between pulp necrosis and transient apical breakdown. Okay, these two can result from dental trauma, for example, following just simple concussion. Okay, you can get some graying of the crown. Okay, and you will get negative sensibility testing. That's very normal. Sometimes you may even get apical radiolucency. Now, problem is that whenever you see apical radiolucency, you cannot jump to point that that tooth is necrotic right away. Okay, why? More on this, but when you see all these signs, things that relate to pathology, pain, sinus, pus discharge, persistent tenderness to percussion, worsening pain, arrested root development, this one, if these are present, you can confidently tell, okay, pulp necrosis is likely the diagnosis. Go in. Okay, so in IADT guideline, just a very recent one, they recommended to have at least 2 signs to be present before you intervene, okay, before you perform any endodontic treatment. Now, what is transient apical breakdown? Transient apical breakdown is these 3, okay, but transient apical breakdown can heal without any form of treatment. Okay, you do not have to do any endo treatment. Okay, meaning if you see a discolored crown following dental trauma, no response to co-test and EPT, and there's even PDL space widening, they are not necessarily necrotic. They are probably just suffering some inflammation. Okay, and this inflammation can heal. Okay, so the best way to confirm if it is still vital or not is to use this thing called Doppler flowmetry. I do not know if we even have this in Malaysia. It used to be very expensive, but nowadays it's just not accessible. Okay, so Doppler flowmetry will actually help to detect detect pulpal blood flow, okay, rather than testing the neural response. Okay, pulse oximetry, can we use the finger one to our tooth? Don't know, maybe just not sensitive enough. I've never bothered to try it. Okay, so just another picture, some illustration. Okay, 2 teeth. This is from a book. I can't recall. Sorry, from a journal. I should have put some citation here, but I forgot. Sorry. Okay, anyway, just want to show you that 2 incisors. One definitely had a very bad crack. Okay, so the end treatment for this one was obviously root canal treatment all the way down. Okay, next for tooth 2-1, you can see there's some slight coronal grayish discoloration at 3 months. And there's even some PDL space widening, you see. From CBCT, this looks fine, but at 3 months, there's some actually tissue breakdown. But guess what? At 2 years, the tissue healed. So what's happening is that osteoclasts were activated to remove damaged tissues, okay, hard tissues. And when the action is taking place, you can see some radiolucency. But of course, osteoblasts will come and repair, and cementoblasts will also come in and repair the damaged structure. As long as there's vital blood flow, as long as there's no toxin from the canal, there shouldn't be any issues like external root resorption. Okay. So how can they suddenly heal? Well, because the tooth is still healthy. Okay. Transient apical breakdown can occasionally also occur on teeth that are undergoing orthodontic treatment. Okay. So just something interesting. Of course, self-regress lah. Okay, moving next. This is about local anesthetics. Okay. This is a major thing that a lot of people still get it wrong, even when they start to practice, even after practicing for 5, 10, 20 years. Okay. So very common lah in when I was in some oral surgery department, I cannot tell where. Okay. When after ID block, okay, you ask the patient, okay, is there numbness on the tongue? Yes. We straight away assume that pulpal anesthesia is achieved. So the answer is wrong. No, not necessary. Okay. But what about absence of tongue numbness after ID block? No tongue numbness. If there's no if there's no tongue numbness following ID block, highly likely your ID block failed. You have to give another shot. Okay. So what you should do is that if there's no tongue numbness, try to get one by performing another ID block, probably at a different orientation. Try to aim the right behind the lingula, or you can probably consider higher up blocks, for example, Gaugates, Akinosi. Okay, but most beginners will experience this a lot. Okay, failed ID block every day. Okay. Now, what about following tongue numbness? Okay, if you straight away conclude that there's pulpal anesthesia, you're very wrong. If you remember about central core theory, only the superficial part of the nerve is numb. The central core, well, the anesthetics may not be able to penetrate all the way there all the time. Okay, so to really confirm if you've got pulpal anesthesia or not, please apply co-test or EPT. Okay, if there's no response, only then you can conclude that probably there is already pulpal anesthesia, but you may still be surprised now. That's why there's always intrapulpal injection as a backup. Okay, no pain when soft tissues are poked. A lot of people do this in oral surgery department before MOS. Poke, no pain, cut open when drilling the bone at the time. Okay, so again, EPT and co-test, they can help to detect better than soft tissue poking, okay, in terms of pulpal anesthesia. Okay, if there's no pain on probing the tissue, it doesn't mean that there's pulpal anesthesia, okay, because you're testing this test is only testing anesthesia on soft tissue, not the pulp, different nerves. Okay, please be careful with patients who reported difficulty in achieving anesthesia in the past. Okay, some people can already tell you, sorry doctor, you're going to have to inject me more, charge more, it's okay. Usually doctors inject me more, they'll say that, or they tell you, sorry lah, time beranak pun LA tak jalan. Okay, so if any of these patients reported of this, 2 shots of LA straight, don't have to think twice. Okay, so please practice some empathy when you get patients like this. It's not their fault. They can't control it. Okay, maybe sedation could help. Okay, another common mistake among dental students, hopefully not among dentists. I saw a few here. Hongzang, right? So typically we see this a lot in simulation lab, okay, where students, when they purportedly claim that they found the root canal openings, actually those are just pulp fonts. Okay, pulp floor should be dark like this. It shouldn't be bright white like this. Okay, this is merely the roof. Okay, this is merely the roof. Pulp floor should be dark. Now, problem is not to say you do not know how to detect, but sometimes in the clinic, for some reason, patients cannot open their mouth wide enough, there isn't enough lighting to get all the way to the back, and there's no endo mirror, you just can't see what you want to see. So this highlights to two things: magnification, illumination, and of course some experience now, huh? All right. So this is an important diagram. Comes out in exam many times. Okay, the landmarks. Okay, so why is this important? When we perform root canal treatment, when we perform our cleaning and shaping and our obturation, we want to end our point here at the apical constriction, never at the major apical foramen. Okay, how are you gonna plane soft tissues? I mean, the surface that diverges from you. Okay, how are you gonna even obturate this well? Okay, you can't. You are aiming at the smallest diameter of the root, which is at the apical constriction. So please remember that. Now, how to apply this? Knowing and applying it are two different things. Okay, this is a common thing. Probably you folks already know. Okay, sometimes if your file is up to 3-4 mm short from the radiographic apex, sometimes you are already at the apical constriction. Please do not worry too much. Assuming that you have a good apex locator, please do not worry too much. But if you have some cheap brands, okay, you may have to test again. So apex locators are more important than your working length radiograph, apparently. Okay, so you do not have to go all the way down here. If you go all the way down here, sometimes your file could be outside the apical constriction already. It could be even touching the bone. Okay, talking about apex locators. So far, Morita is the gold standard. I think it's about 2,000-3,000 ringgit. Okay, it will still spoil someday, but not so soon. At least for the first 2 years, you can still rely on the results. Okay, they will still spoil. If you want to know where, go to UCAM. They're all Moritas. In undergraduate clinics, they're all spoiled. Okay, not to say all, but a lot. Okay, so when not to trust electronic apex locator, I do not know how many of you read user's instruction before using a product. I hope you start to do that now on. Okay, although they only give you the machine, they never give you the manual. You can nowadays download them easily, from the internet. Okay, so this machine is also an electrical device, similar to your EPT. Same thing. Any rule that applies to this machine applies on this as well. Okay, so what rules are we talking about? Any form of electrical short circuit that can take place will give you premature reading. Remember just now? Metal restoration, gingival contact, excessive moisture, poor probe wall contact, these four. Okay, you are doing the same thing, just that this time around, your probe is measuring something in the canal. Okay, so number one, please ensure that your wires are still intact. Okay, sometimes the wire at the hub here, I'm not sure if you can see my mouse though, please let me know if you can't. Okay, the wire could be bent at the wrong angle, so there is some wire damage inside the rubber tubing. You just cannot detect. Okay, and common mistake number two, this hook, sometimes it is not plugged all the way in. Okay, sometimes you may have put it halfway in, or you have put it all the way in already, just that the probe or the hook is loose. So over some time, somehow, well, the probe just slides out without you knowing. Can't see the mouse. Okay, great, thanks. Never mind, it's okay, but at least I hope you can still follow my explanation. Okay, so to check if your electronic apex locator is working properly or not, this is the simplest thing you can do. Just clip your hook and see if your apex locator goes crazy. It should go red right away, immediately. If it is not happening, find out what's wrong. It could be with the hook, with the clip, with the wire, or with the machine, or with the battery. You never know. One of these. Okay. Next, if the battery is low, charge it. Don't use it. Not a good idea. If you can't charge it full, that means don't take so much risk, because if you're not careful, if you're dealing with an open apex, and this open apex is right next to your ID nerve, you're stepping on a landmine, okay? I'm warning you, things can go sour very, very, very badly, okay? Sure, you may have insurance, but reputation is a lot harder to build, okay? So number 2, you can look at this number, 3, 2, 1 apex. This is not 3 mm. It was never stated here 2 mm or 1 mm from the apex, okay? It's just a reading. There isn't even a unit, any unit at all, okay? So this machine is highly accurate, again, highly accurate only when the line is at the apex. That means the file is already at the PDL ligament, okay? So you aim right on this line, the border between red and green, aim at these lines, or 0, reading, we call it. Get that measurement. Your working length is that measurement minus 0.5 millimeter. Okay, get it? Okay, right. You don't have to get to 0, all the time. Okay, no, correction. You have to get to 0, all the time and subtract that reading by 0.5 mm. Okay, some people will think, oh, what if, doctor, I'll just go straight to this line, okay, without ever going to the apex. You'll be surprised. From this line to the apex, sometimes it can range from 0.5 mm to 1 mm to even 1.5 mm. Okay, why? If you're lucky, your root maybe have just one apical constriction. If you're not lucky, your root can have multiple apical constriction or even a lateral canal. See, so a lot of false positives can happen. So just follow this. Go to 0, subtract 0.5 mm. Okay, and of course, your clip has to engage the file well. It cannot clip sideways. If you're using a file that's too short, remember just now I showed you a shortcut. Clip on the probe. Use the probe to touch the file. I do that all the time. Works very well. Okay. So anything else? Yes, even with apex locator reading, please take an X-ray radiograph. You are obliged to do that, especially in a dental school. This is actually a dental legal document. Okay, in case if you extrude any solution or anything out, at least you can prove to them that you are trying to prevent that. You are actively trying to take some precaution measures. You just happen to mess up. Okay, 15 minutes left. I'll try to finish the. Okay, time to go fast. Okay, anything that can give you short circuit, metal restoration, gingival contact, please be careful. If you're taking working length with a metal restoration, sometimes it's a crown, you can't avoid it. At least you can wrap your file with some Teflon tape. Okay, if you have an amalgam filling, replace that with a composite resin restoration. Okay, your restoration has to seal the pulp chamber properly. There shouldn't be any moisture that can get into the pulp chamber, especially from the gingiva. Remember, gingiva contact, that can give you false positive response. Okay, excessive moisture, this is important for a multi-rooted tooth. Okay, if you have several root canals with different working length, excessive moisture in the pulp chamber can lead to false response. You just want the canal to be wet. You do not want the pulp chamber to be wet. And poor tip wall contact. What does this mean? If the canal is big, if your file is small, there is poor tip wall contact. Or if there's immature apex, there's probably barely any contact. Okay, so you have to rely on your working length radiograph. Sometimes just take a CBCT, measure the length. Your working length from CBCT is actually highly accurate. Okay, and of course, some other obstruction could also be blocking you from getting a proper reading. For example, excessive bleeding, pulp tissue. Okay, all right, caries even. Okay, caries can conduct electricity. So please follow the protocol properly. Remove everything caries-free pre-endo build-up before you start to do your excess cavity. Okay, I think I'm about to finish. I'm quite happy. Okay, this is also another common scenario. True tuck back passes on the apical third of the root. Sometimes you can get tuck back in the middle third or coronal third of the root. This is bad. When this happens, there's plenty of space between your GP and the canal wall in the apical third. So why is this a problem? Despite having a nice looking radiograph, there is actually very poor apical seal. It's just like your GP is hanging in the canal. It plays no role in sealing at all. You do not want that because you can't effectively sterilize the canals. Say if they're surviving bacteria, hairy apical exudate can nourish this bacteria, and this bacteria can release toxin to irritate the periapical tissues. So this way, patients can continue to experience persistent discomfort simply because your treatment failed. Okay, another picture. GP, sometimes there's some space between your GP, there's sometimes space between your GP and your dentine. You can try to fill that out with a sealer. To date, probably I'll consider bioceramic sealer if I can't downpack all the way down to working length minus 5 mm. But just so you know, sealer, sometimes you can't fill up all the space, okay? Okay, another false reading. I recently sent this patient elsewhere to take CBCT because I can't find this little monkey. So this canal was so sclerosed that I have to cut all the way to apical third of the root. Only then I can put in a file, size 8. Coronal third, muted, my file just can't get it, okay? But what I want to point to you is that, can you see the mesial root? Sorry, I forgot that you can't see my mouse, I'm sorry. Okay, can you see the mesial root of tooth 27? Actually, this one's 7. Okay, can you see the mesial root of the second molar? There is a very bright opaque object in the middle of the root. Okay, right buccal to it, there is a radiolucent dot. That radiolucent dot is not a canal. That is an artifact in CBCT. Okay, now let's look on both picture, left and right. Okay, you can clearly see, okay, the black streaks is immediately next to the radio opaque filling material. And number 2, the radio opaque filling material seems to have, like, there's a smear, there's some smudge. Okay, so CBCT is very sensitive to detect canal when the canals are empty, but when there's an opaque object inside, you may get false canal. Okay, there isn't even any space, it is just a shadow. Okay, to conclude, I'm happy I'm finishing on time. If you're not sure, don't do it. If you're not certain, ask for advice. If you're really not sure, send the patient out for second opinion. I send patients out for second opinion, really. I'm not ashamed to do that, okay? Sometimes patients just need another person saying the same thing, or, well, I do not know anything. I do not know everything all the time. Okay? Do not be afraid of admitting your limitation in knowledge. It's okay, all right? And just understand that we are never 100% accurate, never 100% successful. We're just human. Okay, so if you like to hear from me more, I'll be speaking again in my deck. I'll have a lot to share. Okay, please attend. Okay, you never see all this in books. A lot of it comes from personal experience. Okay, and I miss these folks a lot. They've graduated, and I hope that you graduate smoothly this year. Okay, and I'm now practicing at iCare 3 Damansara. 3, this is near TTDI. If any of you happen to pass by, look for me. I'll belanja you coffee. If you drink beer, I'll belanja you beer. No problem. Okay, it'll be good to catch up and maintain some networking. Okay, so please follow my Facebook and maintain contact there. You can friend me in my Facebook. I'm okay. Not just professional Facebook. It's okay. In my page, I share a lot of exam materials and also clinically relevant tips. Okay, if you want to refer me cases, feel free to do that. I think that's it. Not bad. 80 slides in under an hour. Okay, so if you have any questions, feel free to address it. If you are shy, you want to text me personally, I'm okay with it. So over to you, Mr. Yusuf Ui.
Yeah, thank you, Doctor. Thank you so much, Dr. Mark, for the sharing session. It is it's very honored to have you here. Yeah.
The honor is mine. There are a lot of exam components here in this presentation.
Yeah, it is sort of like the revision for us as well for the year 5 and year 4 students.
But really, even
Yeah.
if this isn't coming out in exam, they are really relevant to your practice. So there are not many dentists who attended this talk. They are lost. But if any organization want to invite me again, I'll be happy to share again. No problem. Okay. Right.
Yeah, so for the audience part, do you guys have any question? Just type in the text box, because we will begin the next speaker will be begin soon in a few minutes. Yeah. So if there is no question, I think we will be proceeding to the next speaker in a few minutes. Yeah. So the next speaker will be Dr. Lim Tong Wah, who will be presenting the lecture title Resin-Bonded Bridge Revisit. So for the next lecture title will be Resin-Bonded Bridge Revisit. So for the introduction, over the past decade, the development of techniques and materials in dentistry has taken on a renaissance, and adhesive dentistry has predominated. Therefore, the increasing reliability of resin-bonded or adhesive bridge has made them a recommended treatment option for missing tooth replacement and a minimally invasive option to restore the tooth function and aesthetics of the patients. However, the great debates about the survival rates, material selection, and techniques of retainer space creation continues. Therefore, it is time for us to review this treatment option and learn how to adopt them in the modern dentistry. And for the introduction of the speaker, Dr. Lim Tong Wah, Dr. Lim qualified in dentistry from the Faculty of Dentistry in the University of Malaya in 2006. He later proceeded his specialist training in prosthodontics at the Dental Institute at Guy's Hospital, King's College London, and passed the membership in prosthodontic examination, Royal College of Surgeons, Edinburgh in 2012. He is currently a clinical assistant professor in the Division of Restorative Dental Science, Faculty of Dentistry, the University of Hong Kong. Moving toward a new path in Hong Kong, he is currently working as a course director for indirect restoration and MOOC on aesthetic dentistry. He worked as an associate professor in prosthodontics in UiTM before joining the University of Hong Kong. In addition, he is an accredited specialist in prosthodontics, registered with the National Specialist Register and Academy of Medicine. Please welcome Dr. Lim Tong Wah.
Thank you, Chairperson. Can you guys hear me?
Yes, Doctor.
Okay. So first of all, I thank you so much for the invitations. It's a great honor for me to be here today, and then it's always nice to see Malaysian, especially like currently in Hong Kong now. So even though it's virtually, but still happy to do that. So today, upon request and staff actually they're asking me to do some sharing regarding Resin-Bonded bridge, which I think is like pretty relevant to the undergraduate teaching. So presumably, some of the university might not teach so much into details regarding Resin-Bonded bridge, but today I just want to share something regarding this RBB concept, and then perhaps if let's say you are having a chance, and then you might try to do during the training. Okay, so we share a little bit regarding the history regarding Resin-Bonded bridge. It evolved from the rosette designs like almost 50 years ago. So the right-hand side, the picture actually showing you like what is rosette design. So which is, when you see the retainer, you can see some kind of like perforations on the metal retainer. So this kind of design, we call it rosette design. And then other than that, some people, they will try to use the same way, so which is a perforated type for gold metal retainer. And sometimes we can create some kind of like retentions, like using the mesh retentions, acrylic bits, and Virginia sort techniques. So all these things like are a little bit old-fashioned, and then nowadays actually we rarely do it unless you want to make something interim. Then perhaps that is too useful. So how about membrane bridge? I think a lot of people actually tends to call resin-bonded bridge as membrane bridge, or maybe like you're being taught regarding membrane bridge. So so what it really means like membrane bridge? So membrane bridge basically is talking about it was named and also developed by the University of Maryland using the electrochemical etching techniques on the metal retainer. So if let's say you are not using this kind of like techniques on the metal retainer, then perhaps that this is not the right term for you to name it. So nowadays actually we don't really call it membrane bridge anymore. So perhaps that maybe sometimes you need to communicate with a technician, so there's a chance that you need to say it out. But other than that, I would say most of the time we don't call it membrane bridge. I don't think this is the right term to be used currently. So what is the modern type of like RBB nowadays? So I start with the metaceramic type first. So what happens is that we are actually utilizing airborne particle abrasion techniques with 50 micron alumina to roughen the metal retainer surface. The reason we do it is because we want to create a very strong bond between the oxide layer on the retainer and also the phosphate monomer containing adhesive resin. It's not all the adhesive resin contains MDP, so that's something we need to check. If let's say you are not using the MDP base like resin cement, I wouldn't advise you to go for resin-bonded bridge design. If let's say you chose to use noble metal as your retainer, then you have to think about how are you going to create this bonding. So currently, basically, there are three commonly used techniques. Will be metal primer, or you can use tin plating, you can use silica coating, followed by the silane application. So these are the three methods that can be used for the normal metal. So this two picture showing you that before airborne like particle abrasions and also like after. So basically it help you to clean. Second is I help you to roughen it, and the third one is I help you to create a fresh oxide layer. So this is something critical for you to create a good chemical bond between the resin cement and also the metal retainer. So can we use for some challenging situation or clinical situations? I would say yes. Look at these pictures, then you know that we are going to replace canine. So to replace canine, even though using a conventional approach, I think it's still a challenging one. So for this case, actually, we decided to go for resin-bonded bridge. Especially if I look at the case, then we know that all the potential abutment basically are sound. So I can't see a reason for you to cut on the sound tip. I mean, for me, it's like it's a little bit unethical, I would say. So I will avoid cutting whenever possible. So in this case, we decided to go for resin-bonded bridge. So very simple, we design a full complete coverage of the metal retainer, and then we can use the cantilever design and we replace the missing molar. And of course, at the same time, you have to control the occlusion, especially for this case. The other type will be like the ceramic RBB. So nowadays, ceramic RBB basically have shown like a very good or excellent aesthetic. At the same time, it's a very promising survival and success rate. So for zirconia, it's the most commonly used one nowadays for ceramic RBB. What you have to do is airborne particle abrasion with 50 micron alumina, around 1 to 2.5 bar in terms of the pressure, and then 10 millimeter distance, and then using about like 75 to 90 degree angle, and spend about 10 to 15 seconds. Again, if let's say you want to use good cement to bond with zirconia, then again, phosphate monomer containing adhesive resin is always recommended. Some of the cases that we can consider to use like lithium disilicate, because we know that lithium disilicate always achieve a better aesthetic. So if you really want to choose like lithium disilicate, for example, some of the anterior case, hydrofluoric acid etching followed by the silane application will be the recommended procedure for you to do. Another example for my patient, so a small contact, so we use the premolar as abutment, and we replace the small tiny canine using the mesial cantilever zirconia RBB. So as simple as this, then basically like it will going to last long. So what are the material selection for retainer? So basically I would say like two major group. The first one will be the metal alloy. You can choose nickel chrome, or you can choose like normal metal alloys. The second group will be ceramics. Again, it will be like zirconia or lithium disilicate for you to choose. Other than this material, then basically like we don't really have a very good evidence to support. Then I wouldn't advise you to go for it. So when you select the material, I think these are the 6 criteria that you have to carefully evaluate before you plan for the material. First one is rigidity, accuracy, biocompatibility, bonding, aesthetic, and also the cost. What are the advantages by using the RBB? First one definitely is preserve the tooth structure because it's only involve very minimal or even like no tooth preparations. Second is reversibility. So if let's say you really want to or treatment plan the case like in future using some fixed option, for example, like implant, then maybe Resin-Bonded bridge can serve as interim prosthesis. And maybe your patient is kind of like young, then I think that this is another good option. Sometimes a clinician would justify saying that because patient can't afford for the implant, then that's the reason I chose to go for conventional bridge. I cut like 2 abutments and then I prepare for the conventional bridge. But bear in mind that patient can't afford for the implant today doesn't mean that after 5 years they can't afford for the implant. So again, we have to really plan having kind of like long-term planning for the patients. If let's say you think that patients like want to have a more open option in the future, then perhaps that Resin-Bonded bridge will serve much better than the conventional one. Fixed replacement of the missing teeth, no doubt. And then it's advisable to restore the edentulous mandibular distal extension cases using cantilever Resin-Bonded bridge. We did have one study I'm going to share later on, and then to try to compare these two, then we show a very good result from Resin-Bonded bridge. Short duration clinical appointment for the patient and clinician, easy to do, simple to do, low cost. So those are the advantages by using Resin-Bonded bridge. How about the disadvantages? So basically, like I think people always question regarding the success and survival rate of Resin-Bonded bridge. But we have to bear in mind that why it failed. It failed most of the times because of very poor bridge design and also the cementation techniques. So if let's say you can't design it correctly, or you didn't really adopt a very strict protocol for the cementations, then basically like we are expecting the bridge will fail. So if as you do it correctly, basically I would say the success and survival rate currently for Resin-Bonded bridge is relatively promising. Second is a high maintenance care. Again, we have to warn the patient there's a chance for cementation, and of course there's a chance for us to cement it back. Technique sensitive because it requires a very strict surface treatment on the retainer and also the very strict cementation protocol. Compromise aesthetic. If let's say you are using metal ceramic Resin-Bonded bridge, then I would say it sometimes will cause some kind of like graying effect. And occlusion incisor coverage on the metal retainer will be visible as well. So this is something you need to really justify whether it can be used. Otherwise, you have to go for the ceramic type. Limited or to short span missing teeth replacement, difficult to fabricate an interim restoration to maintain the space for the retainer if occlusion reduction is performed. And also the last one will be difficult to redistribute the edentular space. I'm going to share some of the tips like how are you going to overcome it. So this is the study that I'm going to share with you guys, comparing free end saddle restore with Resin-Bonded bridge and free end saddle restore with removable partial denture. So this is a very classic design done by Newcastle. So what happens is that when they compare these two and then they evaluate the caries rates after like I think if I'm not mistaken after 2 years. So what they found is like for those cases restored with denture, and then the caries on the abutment teeth is almost like 5 times higher than the Resin-Bonded bridge. And at the same time, they evaluate on another paper talking about the patient satisfaction by the same group of researchers. And then what they found is the patients from Resin-Bonded bridge group have highest satisfaction rate compared to the denture group as well. So from there, actually, we can start to think, if as you really want to restore the patient into a shorter dental arch, perhaps that you can just restore it using like 2 Resin-Bonded bridge at the back. Then it might work for the patients. Compare, restore it with the denture. And we know that denture not going to work very well, especially for the distal extension cases. So this is the one of the example that from my patients. So the case was referred by one of the orthodontists. This patient is my friend's mother-in-law, basically. So she's asking like, can I help to restore the case with a denture? So when I look at the case, the first thing that I'm thinking is like, is it good to use denture for this case? For the upper, no doubt, I think that resin-bonded bridge can easily solve the problem. But when you look at the bottom one, so conventionally, I would say like most of the people will treatment plan using using the removable partial denture. But when I look at the case, I say maybe there's a chance for us to try to restore it using a couple of like resin-bonded bridge, and now we'll see how it works. So this is the post-op. So basically, anterior, I try to touch up with some of the composite, but all the missing teeth basically were replaced using a resin-bonded bridge. I try to keep the pontic unit small, and then I try to maintain a shorter than the arch for these patients. So this is the post-op immediately photo after the treatment. So basically, that it looks okay. Then I just questions like whether it's going to last very long for this case. I didn't see I'm very bad clinician. I don't have a chance to really review this patient. So I just happened that before I left to Hong Kong, so what happens? I just called back the patient. I said, like, can I have a look on the case? On this case, I just want to see how long the resin-bonded bridge lasts. And this was the photos that it took after 8 years of service. So basically, all the resin-bonded bridge remains there, no problem. There was one caries on one of the abutment. Other than that, all the teeth are good. And then when I spoke to the patient just told me that no, I didn't see. She didn't feel any problems, and then she didn't notice the caries, so that's a problem. So she didn't attend any like regular dental checkout. So other than that, all working well for this patient, and she's really glad. At least like this is some fixed option for her, but not really a removal options. So from there you can see a very multiple missing teeth replacement using resin-bonded bridge. It served up to 8 years. Until now, I believe that's almost 9 years already. So all working well. So we can see the prognosis for the resin-bonded bridge basically it works fantastic, I would say. So something for us to consider when we treatment plan for the case, when we offer the treatment option for the patient. Another challenge is always people will question, because putting the resin-bonded bridge, we can't really redistribute the edentulous space. So 2 cases that I'm going to share cases done by my students. So what happens is very simple. If you are having some spacing, sometimes you can just add some composite there. Both cases, I just have to add some composite on the abutment, and then I try to redistribute the case, the space to make the teeth look identical. So that's something that can be done easily by using the composite. What are the indications by prescribing the resin-bonded bridge? Good quality of enamel, sound or very minimally restored abutment, young patient or patient request. Like some patient will tell you that I don't want my teeth to be cut. So this is the case that you have to think whether you want to go for resin-bonded bridge. Interim prosthesis before you do implant, so maybe you can consider to put a resin-bonded bridge there. Periodontal splinting, sometimes we need to splint the teeth, so we can consider to use resin-bonded bridge if, let's say, there is a missing tooth there. Contraindication, I wouldn't say it's like absolutely contraindication, but it's something for you to consider. Inadequate quantity of enamel, heavily restored abutment, parafunction, endodontically treated tooth. Those are the things that the tooth will be a little bit weakened, then we have to consider maybe the conventional option would be a better choice. Poor quality of enamel, such as like amerangensis imperfecta. So these are the cases that we will try to avoid. Multiple missing teeth, challenging occlusions. So these kind of cases, I would prefer some conventional approach. And definitely allergic. So what kind of allergic can it be? Because we are using nickel chrome, so we have to understand that there are some patients, they might be allergic to nickel. So if that's the case, then I would advise, even though we don't really see it regularly, like if that's the patient having this kind of like allergic reactions because of the nickel, but we still try to be careful. So I will try to avoid whenever I know that patient having some potential allergic to nickel. So factors affecting success of resin-bonded bridge. So these are some tips that I'm going to share with you. Like how are you going to design it? How are you going to evaluate the patient to make sure that your resin-bonded bridge is going to work very well? So the first one is like patient factor, local factor, prosthesis design, clinical techniques. So for patient factor, patient age, young patient, please don't cut the teeth. So I would say that try to avoid conventional bridge whenever possible. If let's say there's a chance, I try to think about, is it possible for us to restore it using a resin-bonded bridge? You have to understand that you cut the conventional bridge for a 20-year-old patient, 30-year-old patient, then how long a conventional bridge can last? I give you maximum 15 years. So what are you going to do after 15 years? An implant? Then after like those are the restorative cycle that's going to happen on these patients. So whenever possible, I always advise my student, try to start with something very, very conservative first. So if possible, I go for RBB. If let's say RBB going to work very well for this patient, it can last 10 years, 15 years. Then after that, if failed, then we can consider the second option might be your another RBB, or you can go for conventional bridge, or you can go for implant. So those are the things that you have to really careful for whenever you treatment plan for the patient. Medical history, check for the allergic reactions. Dental history, where the patient is like auto treatment because teeth move. So those are the design that you will consider if let's say like patient having this kind of treatment before the RBB. Habit. Bruxer, I will try to avoid, or sometimes I try on it, but I will inform the patient the success rate might not be very high. Expectation is something that I'm going to share with you later on. So what kind of expectations that we are from the patient? So if let's say your patient is really, really concerned about aesthetic, tell them, if let's say you're going to do metal ceramic resin-bonded bridge, there's possibility it can be seen by people. So if I look at the posterior RBB, so basically that you can see the full metal coverage basically going to show you the whole metal color at the occlusal surface, so which your patient might be very concerned. If let's say you put on the maxilla, there may be like if let's say you put on the maxilla, so basically like you no need to be so worried because it can't be seen easily, but mandible, yes, I would say. Second thing is like visible or graying effect after you putting the metal retainer. So what happens is like graying effects, you're going to show especially on the incisor chert. So because it's very translucent, so when people view it, they will see some kind of like a gray shadowing on this incisor chert. A lot of patients, they don't mind, but if I say you are practicing in some high-end practice, then be very, very careful. So we have to inform the patient there's a chance can be seen. And of course, we can avoid it, but it wouldn't be like perfectly soft if I say you using like opaque cement. So local factors. So local factors like three things like we have to look at: the size of the abutment teeth, the angulations, the morphology. So these are the things you have to evaluate whether this is a good candidate for you to do the cantilever design. Position, arguably we don't really practice distal cantilever, but for resin-bonded bridge, I think there's a chance for us to use it. Why I say so? Because what is the worst scenario will happen on resin-bonded bridge? It's just dislodge. So you wouldn't get something very catastrophic failure. So I wouldn't worry so much if let's say I practice like distal cantilever. Of course, ideally, I would prefer mesial cantilever. But if I say really no chance, then I still okay with the distal cantilever if I prescribe resin-bonded bridge. Other than that, conventional bridge, I think is a no. And then so whenever you treatment plan, I think it gives you some chance for you to do for distal cantilever. Other than that, just like normal abutment assessment, restorative, endodontic, and periodontal status, something for you to evaluate. How about edentulous space? So sometimes like if you are having a big edentulous space, so very simple, you can just like create some space between the pontic and also the adjacent tooth. So by make the pontic smaller, then basically it will work much better. For molar side, because I love to have a cantilever design, so for molar side, usually you can design into 2 premolar pontics. Other than that, I think this was the case that I showed you previously. So what happens is if I say they have some spacing, then sometimes you can use the metal retainer to use as a palatal template for you to add the composite on the buccal surface. So as simple by doing that, then you have a guide for you to something like a palatal shell for you to add on the composite layer by layer towards buccal. Occlusion is another thing that we have to take care of. Sometimes people are wondering like their resin-bonded bridge might fail very quickly because they never care about occlusions. So the first thing is when you look at the occlusions, we check the interocclusal space because we want to see is there any space occur naturally to avoid us to do further cutting. Second, after you cement the resin-bonded bridge, then we have to check for the guidance. So the guidance on the pontic should be avoided during the excursive movement. So when the patient moves right, left, then you try to avoid the guidance there. If let's say you really, really cannot get rid of the guidance on the pontic, for example, you replace the canine, then I would advise you, maybe we try the share guidance. So share between the pontic and also the abutment. Then maybe it will work much better. So you can see like two cases for me. So what happened is that we try to guide it either on the pontic or on other teeth, like with some group function or canine guidance. But we are trying to avoid all the guidance on the pontic to make sure that it's going to work for works and survive longer. Another occlusion things is talking about how are you going to create space for the Resin-Bonded bridge retainer. So because sometimes I love full coverage, so that's the reason I love to cover the whole occlusal surface. And people always ask like, how are you going to create? Are you going to cut a lot? Yes, there are three approaches basically. So the first one is that you can do some occlusal reduction on the abutment. Second option is that you can do preparing the opposing teeth. The third one is that application of the dowel concept. For the first two approach, I would say it's commonly adopted by most of the people. So occlusal reduction on the abutment teeth is like you just have to precisely prepare 0.5 milliliter occlusal reduction on the abutment for the retainer space. Even though it's clinically, I would say, very challenging, but there's a chance for you to do that. Second is occlusal reduction on the abutment require an interim restoration. So you have to remember, after you do the cutting, you have to make sure that you need to maintain the space. So how to maintain the space? You can't put a protem there. So I will always advise my students, just put some composite or some GIC on the opposing tooth to hold the occlusion. The second one is preparing the opposing teeth. This is not something I really favor. I try to avoid this approach. So which is you have to adjust the opposing teeth. So adjustment of opposing teeth sometimes can be challenging. So you can use some pattern resin to guide you how to reduce. But otherwise, you have to really inform the patient that there's a chance you need to do some adjustment on the opposing teeth. Don't tell the patient in last minute because it gives the patient an impression that you are trying to, your prosthetists have some problem and you try to solve the problems. So I would say get a very good informed consent if let's say you really want to do preparation on the opposing teeth. So what is the application of the dowel concept? It's the approach that I commonly use. And then, so the dowel concept basically is like, is a relative axial tooth movement that's observed when a localized appliance or localized restoration are placed in supraocclusion. Supraocclusion just means that you cement it high. And the occlusion will be re-establish the full arch contact over a period of time. So the use of the dowel concept has been recommended to create a retainer cementing the RBB at an increased OVD. So this approach basically will give you a very minimally invasive, reliable, and very easy way of creating this kind of interocclusal space. And when I was in UITM, so basically we did a couple of research or studies, and we have reported nearly 90% of the complete occlusal contact re-establishment after the cementing of RBB at an increased OVD. So it means that 90% of the cases, basically they will come back to the contact. And another 10% doesn't mean that they didn't come back. It's like partially they come back. So it means that maybe we need a longer time to observe whether the teeth will come back into contact. So we published the study basically. So I don't like to share experience because experience doesn't make sense sometimes. It works for you doesn't mean that it works for others. So I love to, whenever I have doubt on certain things, I love to use study to prove. So this one, a lot of people try to challenge or try to question regarding this kind of approach. Then what I'm trying to do is that then I try to conduct some study and I want to show you the result. So we did this study talking about occlusal force and also the occlusal contact re-establishment with the Resin-Bonded bridge using this dowel concept. So what we found is the dowel concept was supported as a conservative alternative to conventional method for the creation of metal retainer space. So the occlusal force will re-establish after 12 weeks. So it means that after 12 weeks, the teeth will come back and then the patient basically can bite at the maximum occlusal force compared to baseline. Second thing is the maximum occlusal force was similar with different demographic or prosthetic factor. And all the participants achieved the occlusal contact re-establishment regardless the age, sex, locations, arch of the prosthesis within 12 weeks. So basically we just evaluate after 3 months. So if let's say we observe for a longer period of time, then maybe that we can see some other result as well. So after that, we did another study to check retrospectively. So what happens is that we check for the complications. So we notice that there are some complications. This study basically we included almost more than 100 patients. I can't remember exactly. I think it's like 110 or 120. So what happens is that we saw that 14 cases basically have some widening of PDL, so which is quite because that's a little bit high. But the thing is that no other symptom for this except for widening of PDL. But we cemented high. So I think kind of like expect this is normal biological response will happen. And we noticed another problem, which is decementation. We have 9 cases, and we further evaluate or we further analyze these decementations, and we found that why it decemented quite high. This decementation rate is quite high. The reason is because of like there are a lot of design basically are fixed design, because they are doing the fixed to retainer design that it tends to fail. So that's why I keep stress on like talking to you. We have to go for cantilever whenever possible. And this is the latest like case report I just recently published this year. So I showed a very long-term result by using this dowel concept and cement the resin-bonded bridge. So you can see this case basically is like pre-op, and then there was a missing molar, and after that I cemented height using a Messier cantilever resin-bonded bridge. And after 6 weeks, if I'm not mistaken, after 6 weeks, and then the whole occlusion re-established. So you can see all the contact basically is like come into contact. And what happened is like I reviewed this patient after 9 years. And after 9 years, it works well without any complications. So you can see the long-term result. Basically, after the teeth come into contact, it just works like a normal resin-bonded bridge, and it can survive very long. So application of the dowel concept, I think they still have some potential contraindication. I don't really advise you to apply it like all the time. So there are some potential contraindication. The first one is I would say anterior open bite or minimal overbite cases. I would say I would try to avoid, because like maybe the patient will lack of like eruptive potentials. Symptomatic TMD, I would try to avoid as well. Huge horizontal discrepancy from CR to MIP, non-vital abutment or endotracheal tooth, or abutment with reduced periodontium, increased mobility, or active periodontal diseases, then this is the cases I wouldn't touch. And high occlusal awareness. When patients have high occlusal awareness, you need to be very careful, so we don't simply change the occlusion in this way. So what kind of like design is possible for you to do for resin-bonded bridge? I would say this is the 4 commonly used one: cantilever, fixed design, fixed movable design, and combination, or we call it hybrid design. Cantilever design is my favorite design, and then basically like if I should look at the study, this is the study, this is the design well supported by all the study. So high success rate, high survival rate, and then provide freedom of movement, avoid partial discementation, because when it fail, it just dislodge the whole thing. It wouldn't dislodge halfly. And then we did a study, and then we found that much lower discementation rates compared to fixed design. So sometimes if you really go for fixed design, then basically you have to warn the patient. There's a chance that you might get partial decementation due to the different movement of the abutment teeth. And usually indicated in long edentulous span or small abutment tooth, which requires additional support or retention or resistant form. And the last one is that whenever you really have no choice to design in fixed, then you have to make sure that the context and MIP and excursive movements should be on the retainer. How about fixed movable design? Is it possible for us to design fixed movable for RBB? Yes, the answer is yes. We can use a non-rigid connector to allow minimal lateral or vertical tooth movement. And then the connector side, the movable joint basically will serve as a stress breaker. So 2 ways for you to do it. One is that you can use the custom-made in resin, or second one is you can use the prefabricated plastic pattern to make the movable joint. So currently in Hong Kong, so we have like 5 years and 10 years like cumulative survival rate for posterior fixed movable design, so which is 82% and also 74%, so which is not bad at all in terms of the survival rate. So how it looks like if you're talking about a fixed movable joint. So this is the fixed movable joint for the resin-bonded bridge. So basically we create a movable joint, usually we design for the smaller abutment side. Then this Patrick's basically will help you to hold the other, the pontic from the bigger abutment. Another case that can be done. So you can see one canine, one molar. So what happens that because it's quite a long span, we have to do like 2 unit pontic. So what happens that I will use the molar to cantilever 2 units. And then you will notice that the design, it looked very different, and the design looked a little bit different compared to the previous slide. So this is a very typical Hong Kong U design. I'm going to share with you the concept about this later on. Okay, the fourth design is something we call like combination design or hybrid design. So it's basically indicated if one abutment is sound and minimally restored, another one is heavily restored and require cuspal protection. So it means that one you need a crown, another one is no problem at all, then we try to restore using Resin-Bonded bridge, and we combine them together. So this is something we call like hybrid design. So the patch is associated with the pontic or connected with the material retainer. This is something I would advise you to do. So these are the 2 cases done by my students. So basically it's that one is Resin-Bonded bridge, another one is a crown. So we can have like 2 different approach. One is like using the intracoronal precision attachment, another using the extracoronal precision attachment. So both are hybrid design. So one is using the Resin-Bonded design, another one is using the conventional crown. So by combining these 2, then you can see that we can work out for a lot of different kind of cases. How about the framework design? So I would say that complete coverage is my favorite choice. And then I practiced this complete coverage like many years already. And then this was what I taught the UITM student to do. So which is using complete coverage for most of the Resin-Bonded bridge cases. So when we talk about complete coverage, we are referring to the full occlusal or full incisor, and also the proximal and also the palatal surface coverage. A typical example that can be shown is this case. Basically, you can have a look on the incisor and also on the premolar. So the whole incisor edge and also the whole premolar occlusal surface were covered by the metal retainer. And you can look to the proximal side with the same, and also the palatal surface will be full coverage. So this is something like a 3/4, I would say. And then this is the complete coverage design, and definitely it's my favorite design. And even though when I was in UK, so this is the recommended design by most of the articles. So when I come to Hong Kong, so what happens is that I learned another thing, which is that we are using partial coverage. So, but if first you want to use partial coverage, then the design will be slightly different. It works very well in Hong Kong. In Hong Kong, you basically, like all my students, they will have chance to do 4 to 5 Resin-Bonded bridge per student. So they are having a lot of experience in Resin-Bonded bridge. So basically, like they will do it routinely all the time to replace the missing tooth, and then it works very well because we have a lot of good studies to support about the survival rate of Resin-Bonded bridge. So this is one of the examples that commonly used here. So what do you call it? We call it D-shaped design. So this D-shaped design is talking about the coverage about 200 degree or 270 degree. So usually like we will design like an occlusal bar, and then we will have a coverage for the proximal and lingual wrap around. And the last one is that we might design into like a cow horn design. The cow horn design is basically to create a more coverage. Maybe we can extend the coverage until like 270 degrees. So what it means like cow horn? This too is called cow horn. It's a real cow horn actually. So this design is like very typically or frequently used in HKU. Another designs that we would do is like 360 degree wrap around with resit, because we are doing the whole 360 degree wrap around. So and then we prevent the vertical dislodgement by putting like 2 resits here. If as you are cantilever a very big unit pontic, then you can go for an occlusal bar as well. So basically we are kind of like playing with this kind of design for the partial coverage. So and it works very well in HKU. So framework design, if let's say we go for the metal ceramic, so some fundamental concept that you need to bear in mind. Thickness is 0.7. I would say 0.5 to 0.8 would be fantastic. Connected height will be 3 mm, and then you have to extend until proximal whenever possible. So sometimes like very difficult for you to locate the Resin-Bonded bridge, because like if you just imagine it's just for anterior, it just adapt on the palatal surface, and then unless you really put on the incisor coverage, for example, like this case, if let's say you didn't put on the incisor coverage, then basically they will just go everywhere whenever you want to do the cementation. So I will always advise you to cover the incisor edge. If let's say your patient say, no, I don't like to have it shown at my incisor edge, then you can trim it off during review visit, okay? So, but at least it helps you to do help you to locate the resin-bonded bridge during cementation. Other ways to do it is retentive tack, incisor hook, and also positioning jig. So these are some examples for you to locate the resin-bonded bridge. But bear in mind that you can trim it off after the cementation. How about zirconia? So if I say you are choosing to go for zirconia design, then I would say maximum coverage for the retainer, proximal, occlusal, buccal, palatal. This is my favorite design. Then connector, you have to make sure that at least 3 mm vertically and also 5 mm horizontally. Pontic, yeah, you can go for any type of design. And then thickness, at least 1 mm. Okay, you go below 1 mm because it's zirconia, it will break. If I say you design for the anterior, then I would say another thing you will consider is maybe we have to remove 2 mm away from the incisor edge. The reason I do that is because we want to achieve a very good aesthetic, so we want to maintain the incisor translucency. Pontic, I mean, most of the cases you will go for modified ridge lap. For very, very aesthetic cases, I think I would advise you can consider to go for ovid, but it's not all the cases can do ovid. You have to design, you have to mold the soft tissue. So this is the way that I mold the soft tissue. So you need to really mold the soft tissue until you get the proper papilla. Then and also the nice indentations. Then from there you can go for ovid design. Then whenever you assess the emergent profile for the Pontic, that you can see a very nice emergent profile, and aesthetically I would say it's perfect. Another things that I'm going to share with you is that what happened in HKU is like split molar design. So this is something we call like split molars. A molar size of edentulous span. So what happens is that we try to split the molar into two cantilever design. We try, whenever possible, avoid fixed design. So that's the reason we try to go for cantilever. So whenever you want to split the molar, then you have to section into two. Another good pictures from Prof. Botello actually is like, yeah, I got my permissions from Prof. Botello, so he shared with me regarding the photos. So you can see molar replacement, but they try to split the molar Pontic into two. Then you can do the distal cantilever and mesial cantilever using this approach, and it works very well. Some people, they will ask, can I cut? Can I prepare some groove? Of course you can, but you have to remember that by do aggressive preparation, the patient might experience dentin hypersensitivity, and it's a very aggressive approach. Longevity, people might feel that it might work better because it's got some retentive growth, but to be honest, evidence show that it's not. It's the other way. So the longevity, I would say, questionable. Reduce the surface for bonding, inaccurate casting or CAD-CAM fabricated prosthesis, and difficult to remove if, let's say, it's partial decemented prosthesis. My own recommendation would be no preparation or minimal preparations. Whenever you want to prepare, limited to removal of undercut, or maybe you do proximal guide plane. And you know what happened here is like we even, whenever we want to extend the coverage, for example, to 360 degree or 270 degree. So how are you going to do that? We're not going to cut it. We're going to use auto separator. So we're going to put the auto separator there. We open out the space, and then to make sure that our metal can go into proximal. So this is how conservative we are whenever we come to resin-bonded bridge. How about the zirconia retainer? So zirconia retainer is like another paper from Prof. Matthias Kahn is the one that really talk about zirconia RBB. He has a lot of good study to show you that it works very well. So this is the very typical example that he will advise you to do the preparation 2 mm away from the incisor edge, and then you can create something like a proximal box because you want to locate the connector. So to accommodate the connector size, then basically like you need the proximal box. The last one is the small pinhole at the palatal surface. The reason that we do small pinhole is because we want to locate, because if as you look at this case, you know that whenever you put the retainer there, the retainer will move everywhere. So what happens is that you need to put a small pinhole to make sure that when you locate the retainer, it will fix there, and then it wouldn't move during cementation. So that's the reason we put the small pinhole there. Okay, so ridge preparation. If let's say your patient having a very severe volume loss after the extraction. There you can think about pink porcelain. I'm a prosthodontist. I love to have pink porcelain sometimes. And then if I say you don't want to have something artificial, then you can think about to do a connective tissue graft. If I say the ejaculate span is not so bad, then for heel socket, you can use electrosurgery to contour the tissue to make a nice emergent profile. Otherwise, if I say you're having a chance to plan during the extraction, I would say you can modify the master cast, and then after that you can get a very nice scallop appearance, just like I show you in this picture. So from there, whenever you locate your pontics there, then it will look very nice emergent profile. Okay, the third tips regarding the clinical techniques will be the shade selection. So because we are using, if let's say you are choosing to go for metal retainer, then you have to think about metal retainer going to show some grayish appearance. Then we always use opaque resin cement. To use opaque resin cement, how are you going to take the shade? So put a cotton roll at the back of your abutment. Then from there, you take the shade. That is the best way for you to do. The other option, of course, you can use the opaque temperate cement. So these are the example that what kind of cement or what kind of like primer that can be used. You cannot simply use all the resin cement. So the resin cements containing MDP will be recommended. These are some of the resin cement that I will recommend you to do. The most recommended resin cement for resin-bonded bridge will be Panivia. So very unfortunately, we don't have Panivia in Malaysia. So because of this, so in Malaysia, I try to go for Relax X Ultimate. But in Hong Kong, basically, we are using either the F2.0 or using the latest version, which is Panivia V5. So many years ago, actually, I remember when I first came back from UK, actually, we still have Panivia in Malaysia, but unfortunately, they stopped the market in Malaysia. So because of this, we don't have a chance to try this very, very good cement. So if let's say you are having a chance, I would say go for Panivia, okay? And then for metal, for ceramic, for example, like zirconia, then please remember normal gold alloy, you have to go for alloy primer. And if I say zirconia, then perhaps you have to apply the ceramic primers there. So this is the sequence that how are you going to do for the cementations. First is like sandblasting using 50 micron alumina, and then whenever you do sandblasting, advise your technician try to cover the pontic using wax or using some glove. Otherwise, like when the sandblast on the porcelain, it will going to create some crack line there that it might break one day. After that, followed by the steam cleaning. If let's say you are using high precious metal or gold alloy, then you have to go for metal primer. And then clean the teeth using Parmesan water, acid etch enamel, and then after that, you can apply the ED primer if let's say you are using Panivia. If let's say you are using the Relax X Ultimate, you can go for their Scotch Bond. Chose the resin cement which containing MDP, and then for metal retainer, go for opaque cement. At the end, you can apply some glycerin and do the final light cure. How about zirconia retainer? So if I say using zirconia, this is the very standardized like cementation protocol. The first one is using 50 micron alumina. Pressure is about 1 to 2.5. You cannot go for very high pressure because it's zirconia, it's going to break. And then 10 to 15 seconds. This is the surface treatment that you have to do for zirconia retainer. Second, steam cleaning. After that, apply the zirconia primer. And then go for Parmesan water, clean the teeth, acid etch, apply the adhesive. If as you are using Panivia, go for the ED primer. And then at the end, resin cement, which containing MDP. So this is a very standardized protocol that it can be used. Another chance for you to try for zirconia is like you can go for cojet and silane. Cojet is something like a silica particles that are going to sandblast on the zirconia. So from there, because they got some silica particle, they're going to embed it on the zirconia. So at the end, you're going to apply the silane on top of the silica. So this is another way there for you to do for chemical bonding. How about the survival rate? So we have like a lot of like good studies about the survival rate of resin-bonded bridge. So especially talking about metal ceramic. So metal ceramic having a very good study since like 1993, you can see. And then we have a lot of like a big sample size study, and then it tell you that the survival rate for resin-bonded bridge is almost like 91% after 5 years. So how about zirconia? So zirconia is something more recent. So you can see the year of publication is like basically it's talking about 2014, 13 and 14. So 2013 and 14, so they show that very good survival rate for zirconia. So it's almost like 100%. But bear in mind, if let's really look at this study carefully, then we know that all the studies are conducted by Matthias Kuhn. So basically, we have looked at one research group. So perhaps that we can have more research group and tell you that the survival rate for all ceramic resin-bonded bridge. So to compare different kind of like treatment options to replace the missing tooth. If let's say you go for fixed conventional design, so the 5-year survival rate 93, 10 years 89. So but compared to resin-bonded bridge, the 5-year survival rate about like 91, and then the 10-year survival rate about like 82 to 83. So basically like they are not so much different. So the weakest one basically I would say is cantilever conventional bridge. So the 10-year survival rate is dropped until 80%. Another option is like tooth implant supported bridge. So if let's go for tooth implant supported bridge, then even lower. So it's only like 77.8% after 10 years. So from there, basically I can tell you that most of the design works well. You can go for fixed conventional, you can go for implant supported single crown, implant supported bridge, or resin-bonded bridge. But bear in mind that resin-bonded bridge is that we don't cut. So you don't cut anything, you achieve such a good result. So I can see the reason for you to say no to these treatment options. So how to manage failure? So basically like to manage failure, the first one I would say biological complication. It's exactly the same with all other prostheses. Caries resin-bonded bridge, the biological complication is about 1.7% compared to conventional bridge, which is 4.8%. Recurrent periodontitis is even less than 1%. Abutmental fracture is 0.2%. Loss of vitality. This is the case that I did my study, and then we found that there are 2 cases basically a loss of vitality, and we don't know reason, to be honest. We don't know the reason, but we suspected it's because of the pre-existing crack. So because of this, so there's a chance that it end up with loss of vitality of the case. How about the technical complications? So Choma et al. Found that the estimated 5-year decementation rate is around like 15%. So they compared cantilever and fixed. No doubt, cantilever works much better and is a significant result. Anterior works better than posterior, but the result is non-significant. Maxilla works better than mandible, but again, it's not significant. Zirconia and metal ceramic have more lower material stripping rate compared to any other materials. And another study by King, they found that minimal unprepared abutment has the least failure rate. So it means that if as you cut more, basically is that you are having higher chance to fail. This is another example. I remember this case was I saw the case when I first came back from London. So when I look at the case, I was like surprised. Why 2 retainers? So this is such an old-fashioned way. So because of this, when I look at the patient, I know that it's going to fail. And the answer is yes. When I use the floss, I floss it. That I found that the weaker abutment, which is on the lateral incisor, basically this is partial decementation there. So because of this, I take out the whole bridge and then I cut off one of the wing and then I cement it back. So this is usually the way that we approach or we manage for the fixed design. Another very challenging part, which is the aesthetic complications. So 2 main problems, I would say. The first one is graying effect. The second one would be visible retainer. So whenever you have a graying effect, how are you going to manage it? You can consider to put some composite veneer if let's say you want. Second one is like more commonly adopted would be putting the opaque cement. If let's say it's visible retainer, for example, in this case, so the first approach that I try to do is I try to sandblast the incisor, the canine tips, and then I try to make the whole appearance like dull. But after that, it didn't work. The patient's still not happy. So patient said, no, I don't want to have any gold appearance there. So no choice that I put the opaque composite on the buccal surface to mask the metal retainer. Another thing that I try to convince you guys is, even though we are having an incisor edge like with metal retainer, actually cannot be seen. Have a look on this case, you know that you can see like all the metal retainer on the incisor edge. But when the patient smile, bear in mind that when the patient smile, at the back of our oral cavity, basically it's kind of like a black. So compared to the metal color, basically it can't be easily seen by the patients. So you can show some good photo and tell the patients that it cannot be really seen. But if your patients are so high expectation about the aesthetic, then no choice. Then we have to redesign inside age. But my personal experience, throughout the years, is like with the incisor coverage always works better. The last one is like, if as your patient really think that no, they don't want to have metal, then we go for zirconia. So zirconia provide you with a very aesthetic result, very good longevity, and very biocompatible because they don't have nickel. So it should be works on all the allergic case. So this was the patients that I think is the last RBB patients that I managed in Malaysia. So what happens is that patient is a very high aesthetic expectation. She is a foreigner and she have one failed endo, and then we have to take out the tooth. So after take out the tooth, because I plan start from beginning, so I try to create a very good edentulous contour and good emergent profile for this case. So I contour it since the denture stage. So at the end, you can see you can get a very nice scalloping with a very nice preserved papilla there. So this is the aesthetic result that we really want. So at the end, we just have to design your zirconia RBB for the patient. So by doing that, you can get a very aesthetic result, patient happy, so everything works well. So with that, thank you very much. I hope that I have shared something slightly different in terms of the Resin-Bonded bridge. So in case that you want to connect with me, then you can always like drop me a message in using IG. If let's say you want to really email me for more details, explanations, or collaborations or anything, then you can always email to my HKU emails. So from there, thank you very much, and I hope I wish all of you like all the best, and then hope to see you one day, not virtually anymore, face to face. Thank you very much.
Okay, thank you very much, Dr. Lim, for the sharing session, and hope to see you soon in Malaysia one day.
Hope so.
Okay, thank you, Doctor. So now I would like to invite all the participants and also all the participants to go back to the main link for the closing ceremony and also the lucky draw and the announcer of the winner. Okay, thank you very much.
changes into something red. Her mother doesn't like that kind of dress. Everything she never had, she's showing up.
Good evening, everyone. We meet again after a long day of competition and learning. I hope that you had as much of an exciting journey as I did, gaining knowledge every step of the way. I'm ecstatic to announce that it is now the most awaited time of the event, the lucky draw. We are going to pick 6 lucky people from the wheel that will receive fun prizes. The lucky person that will be receiving the sectional metric is Nur Hamimi binti Cik Hamai. Congratulations to you. So next, let's see who will be receiving an electronic toothbrush. Lucky Nur Izati Aisha, you will be getting this pro taper. Okay, so now let's take a look at who will be receiving the dental intraoral mirror. I'm sorry. Now let's take a look at who will be getting this burst set. Congratulations, Lohini. You got this you got this burst set. I'm very sorry for that. So now let's take a look at who will be getting the 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 electronic toothbrush. Congratulations, Afikah Nadia. You will be getting this electronic toothbrush. So now let's take a look at who will be heading home with this elect sectional metric set. Congratulations, Abdul Kalam Azad. You will be getting this sectional metric set. Congratulations. Now, let's take a look at who will be receiving this dental intraoral mirror. Congratulations, Latifah binti Ahmad. You will be heading home with this intraoral mirror. Congrats to everyone that have received this lucky draw prizes. So now, let us go to the award-winning ceremony for each of the competitions today. The second runner-up for each of the competition will be receiving RM 150, an e-certificate, and also plaque. The first runner-up will be getting RM 200, e-certificate, and plaque. And finally, the winners will be taking home RM 300 ringgit, oral irrigator, e-certificates, and plaques. Without further ado, it is time to award the winners of today's competition. Let's first start with oral presentation. The second runner-up goes to University Kebangsaan Malaysia. Congratulations. The first runner-up goes to University Technology Mara. Good job, everyone. Lastly, the winner of the 14th NDSSC oral presentation goes to University Science Islam Malaysia. Congratulations. Well done to all teams that have participated in oral presentations. We definitely have learned a lot with your presentations today. Next, let us proceed to the e-poster competitions. The second runner-up goes to University Malaya. Congratulations, University Malaya. The first runner-up is University Science Islam Malaysia. Congratulations, good job on your amazing work. The winner of the 14th NDSSC e-poster competition goes to University Technology Mara. Good job, everyone. Congratulations to the winners of the e-poster competition and to everyone that had participated. Now on to the next competition. I will be announcing the winners for the quiz competition. The second runner-up goes to LUC1. Congratulations, everyone. The first runner-up of the quiz competition goes to UKM1. Well done. And lastly, the winner of the 14th NDSSC quiz competition goes to IMU1. Good job. Congratulations to all of the winners for the quiz competition. Next, we will take a look at the photographs that won the photography competition for this year's 14th NDSSC 2022. There were many photographs that were posted, also beautiful and interesting in their own way. Thank you everyone for their hard work and participation in this competition. Now let's take a look at the winner for Best Creativity. Best Creativity goes to Wong Chin Wen from Lincoln University College. Wow, what a great picture, don't you think? Do you know why this picture won Best Creativity? It is because the mirror represents a pair of eyes and the sharp probe represents a smile. How creative! What a unique smiley face. The caption says that it is always nice to see a smile on our work buddies. The best romantic picture goes to Fariha binti Fatul Karim from University Science Malaysia. Congratulations! That is such an aesthetically pleasing picture. The caption reads, "We keep smiling because we believe there's always a rainbow at the end of the rain." That is a very deep and loving caption. Lastly, the best team of the 14th NDSSC photography competition goes to Lee Min Kwan from Mahsa University. Congratulations, Lee Min Kwan. That is a fantastic picture. The caption reads, "Perfect smile? Put on your lip gloss, but don't forget to floss. Want to look pretty? Apply cosmetics. Dental health matters." Good job, everyone. Lastly, we now have the videography competitions where we will be displaying the top 3 winning videos. Let us all sit back and enjoy the videos from the winners.
Kenapa ni, Is? Kau kenapa sedih sangat ni? Sabar. Cuba cerita dulu kat aku. Kenapa ni, Is?
Girlfriend aku baru tinggalkan aku doh.
Lah, kenapa dia tinggalkan kau?
Aku pun tak tahu lah. Dia cakap sebab gigi aku.
Gigi kau?
Ha,
Teruk sangat ke gigi kau?
tak tahulah teruk ke tak. Before ni aku okey je sebab pakai mask. Tapi sekarang santai bila makan. Kau nak tengok ke?
Tunjuklah kat aku gigi kau. Allah. Ni bukannya girlfriend kau, dia nak tinggal kau. Aku gerak dululah.
Semua orang nak tinggalkan aku. Tak apalah. Tengok IG dulu lah. Buruk sangat ke gigi aku ni? Patutlah orang tinggalkan aku. Apalah orang ni.
Buruk dah gigi. Selalu dia gelak kawan-kawan.
Ni pasal gigi ni.
Dia tinggalkan awet. Sorry. nak cantikkan gigi, saya banyak testimoni. Sila bumi
Apa
saya
nombor doktor
di
ni?
deskripsi di bawah
Boleh
ini.
ambil ni.
Call saya, okey?
Sini lancar. Sana lancar. Hari-hari lancar. Berdosa. Sini lancar.
Buruk dan gigi selalu digelak kawan-kawan. Ditinggalkan awet. Sorry.
Ish, tak boleh jadi ni. Aku kena buat sesuatu. Uish, not bad. Laju juga doktor ni reply. Uish, motor pun kemas. Anytime, anywhere also can. Jadilah.
Duduk.
Ni doktor T ke?
Ya, kamu siapa?
Saya yang kontak doktor.
Oh, okey. Baring.
Baring sini ke doktor?
Ha, sinilah. Profesional ni.
Doktor, gigi saya.
Tak apa. Saya tahu kes ni. Macam mana nak buat ni. Hehehe, senang je ni.
Doktor. Doktor!
Uish, boleh tahan juga dia buat ni. Cantik ni. Oh, macam artis lah.
Aduh, kenapa aku rasa gigi aku rasa sakit tu misai. Aduh, nak kontak doktor T lah. Doktor, kenapa gigi saya masih sakit? Sudah seminggu ni. Doktor, reply lah.
Kamu siapa?
Saya lah yang jumpa doktor hari tu. Kenapa dia block ni? Doktor? Reply lah doktor. Ha? Doktor tipu sama lu? Doktor penipu!
Hi, I'm Asfar, and I have been chasing my dreams for the whole life, but the emptiness is conquering my heart. Exhaustion, pain, frustrations, these three things make up most of enemy. The feeling of quitting from chasing my childhood dream, sometimes the only solution that I can think of. Life is a place where the mixed feeling happen. You can't control what you're gonna feel, and you can't imagine what you will end up with. The smile is fading, and the weight of disappointments and failure is draining my soul. It's so easy for people to say, just mask your smile, cover it with some laugh, join the group, blend your life with others, and socialize until to the point that people believe you are happy with your life. But behind it all, I'm still wounded. I have been hit by my mistakes, my regrets, my insecurities, and my unreachable desires. But actually, you can choose what you want to feel. Find positivity, find happiness, and find your own achievements. Life can be heavy, especially if you carry it all at once. So decide what is to hold and let the rest go. find the silver lining in every cloud you face, because every day that you wake up is the sign that the best is yet to come.
Smile is a curve that sets everything straight. What about those who has lost it? This is how we restore a perfect smile.
Complete denture is not just a prosthesis. For us dentists, it's how we express our art.
Congratulations to Lincoln University College, University of Science Islam Malaysia, and Penang International Dental College, as well to everyone that has participated. Those were certainly very interesting videos and deeply motivational. Your talents are truly mind-blowing. Next, we will have a closing address by Malaysian Dental Student Association President, Mr. Tony Leng Wen Hao. Welcome, Mr. Tony.
Hi, good evening. First of all, am I audible and visible?
Yes, Mr. Tony.
All right. Very good morning to everyone. I'm Tony Ling, the current president of NDSSC. First, I'm very honored and delighted to deliver the concluding remarks on the National Dental Student Scientific Conference 2022, held by Lincoln Universities. I would like to appreciate all the hard work and the organizing committee as they put their heart and soul to make this event happen. This conference is one of the biggest events among all the 13 dental universities, and seeing it's held at this marvelously and all the university took part in this competition really shows that students are engaged in the research field and how bright the future are for us as a dental student. Next, I would like to appreciate and take the opportunity to all the sponsors, media partners, and whoever helped in the preparation of this event. Your contribution is one of the key factors to make this event a success. Lastly, congratulations to all the winners in the poster presentation case, and all the video photography competition. And to all the other participants, don't be sad, always can try next year. I hope that we all have learned something from this conference and make a use of it in our future. And with this, I end my speech for the closing ceremony. And once again, thank you. Hope you all have a good day.
Thank you, Mr. Tony, for that amazing speech. Now, I would like to welcome the Dean of Lincoln University College, Prof. Dato Dr. Pushparajan Pillai, to pass the NDSSC baton to University Malaya via a short animation. Next, let's have an acknowledgement note by Prof. Zamri bin Razi, the 15th NDSSC Dean. Welcome, Prof.
Thank you very much, Master of Ceremony. Congratulations to all the winners. And I would like to take this opportunity to congratulate Faculty of Dentistry, Lincoln University College for the great and most happening 14th National Dental Student Scientific Conference. Congratulations. On behalf of the organizing committee of the next NDSSC, University of Malaya, we would like to welcome you to the 15th National Dental Students Scientific Conference 2023. Thank you.
Thank you very much, Prof. Lastly, let us welcome the chairperson of 14th NDSSC 2022, Mr. Lee Ji Peng Xavier, for a note of gratitude.
Thank you, Miss Humara. Am I audible and visible?
Your voice is
Hello.
not very clear, Xavier.
Hello. Am I audible
Now
now?
it's clear. Yes.
Okay. Yeah. Honorable Prof. Zamri bin Razi, Dean of Dental Faculty of University Malaya, respected Prof. Dr. Pusparajan Priyana Pillai, Dean of Dental Faculty of LUC, respected Tony Lang, President of MDSA, our most valued invited guests, ladies and gentlemen. It's my privilege to have been asked to propose a vote of thanks on this occasion. I, on behalf of the Lincoln University College and the organizing committee of the 14th NDSSC 2022, would like to extend a very hearty gratitude to all the chief guests and speakers for sharing their graceful words with us at today's conference. I would like to extend a very hearty vote of thanks to the invited speakers, Dr. Mark, our Endo lecturer, who is willing to personally sponsor our conference, and also Dr. Tong Wah Lim, who is virtually present us with us all the way from Hong Kong. Okay, thank you both for gracing your important knowledge and sharing the knowledge with us today. I'm sure that the college really I'm very sure that the students are really learn a lot today. Next, I'm thankful to all the participants for joining the competition and attending the conference. The centerpiece of the 14th NDSSC 2022 is that the students shall be able to gain a wonderful knowledge, experience, insights as meaningful souvenirs of 14th NDSSC 2022. Even though we are meeting on a virtual platform, but making new friends and expanding the circles are also possible. I would like to commend my committees for their hard work to launch this event. It really took sweat, tears, and lots of sleep depths to make the 14th and National Dental Student Scientific Conference turning into a reality. Last but not least, special thanks to our platinum sponsor, Aquapix, our gold sponsor from Mark Endo Specialists, and silver sponsor from Enden and MJ Dental Supplies. Thank you for sponsoring us. And our collaborator, MDSA, as well as EPDSA, for helping us to take this virtual conference to a broader social media platform. And before I end this, I wish all the best for the next organizing committee of the 15th NDSSC 2023. Thank you and have a great day ahead.
Thank you, Xavier. Before we adjourn, we would like to thank the Malaysian Dental Student Association for collaborating with us, as well as the Asian Pacific Dental Student Association for being our social media partner. Everyone present here today has played a big part in each of our education journeys. Thank you for sharing your knowledge and experiences with all of us. I hope that we thrive together as one unit to become successful dentists in Malaysia, surpassing every limit to success. I now would like to ask everyone present here to turn on your cameras along with the backdrop for a photography session together. Please turn on your camera, everyone. Before I end this, I would like to quote the great Malcolm X. Education is the passport to the future, for tomorrow belongs to those who prepare for it today. I hope everyone had a good time. It was an absolute honor to MC the 14th National Dental Student Scientific Conference 2022. Have a great day. I am Humaira Zafira from the Faculty of Dental Lincoln University College, signing out. Salam satu Malaysia, everyone.